Good morning, everyone. Welcome to the Self-Supervised Learning for Cancer Pathology Foundation Models workshop here at NeurIPS. My name is Neeraj Kumar, and it is a pleasure to have you all here. Pathology foundation models have increasingly reshaped how we study cancer and build predictive systems for diagnosis, prognosis, and treatment planning. Recent large-scale models have demonstrated remarkable potential, but they have also exposed a major barrier. Developing these foundation models normally requires massive, well-curated pathology data sets and deep domain expertise. One of the core objectives of organizing this competition was exactly to address this barrier, to provide participants with access to a large-scale, diverse pathology image data set, enabling them to focus on self-supervised learning innovations rather than doing the heavy lifting of data collection and pre-processing. The competition centers on building self-supervised pathology foundation models, then evaluating them on a broad set of clinically meaningful downstream tasks such as cancer subtyping, biomarker prediction, and survival-related outcomes. All these tasks were carefully curated with our partners from Memorial Sloan Kettering Cancer Center, Mayo Clinic, MD Anderson Cancer Center, Stony Brook University, and University of Carolina at North Carolina at Chapel Hill. We thank all the participating teams for your dedication, creativity, and contributions. And one important logistic reminders, if you haven't sent your presentations to Chad, please just email them to Chad because we have just one computer connected here to the audiovisual system. Thank you. Now, the structure of this workshop will be, Chad will provide update on the current status of the competition, followed by invited talk by Professor Christopher Kanan. And then we will have participant presentations. Each participant will have 5 to 7 minutes to present their work, followed by presentations from the organizing team. Each of the organizing team members will have 10 minutes for their presentation. And organizing team members also please send your presentations to Chad if you haven't done so. Now I'll invite Chad to provide current state of the presentation. We also have an exciting job opportunity that Greg will talk about at MSK. So I'll first invite Chad to talk about the current status. Thank you.
Hello, everybody. Thank you so much for coming. Really good turnout so far. We were at the workshop before this that had much less turnout, so there's a lot of exciting interest in pathology. We're glad to have participants come from all over the world to be here. Let's see. Okay, so my presentation is on the state of the competition, which I'll talk a little bit about. So this work is funded by the Warren Albert Foundation through our Warren Albert Center for Digital Computational Pathology. It's a named center at Memorial Sloan Kettering Cancer Center in our Department of Pathology. They provide resources for all of our computational work. Also, very important, Amazon Web Service has agreed to cover the cost of storage and egress of all the data, so that because this data set is so enormous, I had a budget from the center that could have been overwhelmed very easily with so many people participating. So we're very grateful that they stepped in and they're willing to fund it. It gives me less stress. Okay. I also want to acknowledge people at Memorial Sloan Kettering Cancer Center who've been very supportive of this project. It is a little bit of a challenge, as always, to share data, especially when it comes from clinical patients. So we've had great partnerships with people in my department, the Department of Pathology. We're also working with our legal people who many of you who are participants have probably interacted with to try to get the agreements signed in the orderly fashion. It's a little bit unusual for them to have to push through 30 or 40 data transfer agreements. So we're thankful for them. And also the Data Governance Committee, who we've worked closely with to make sure that everybody's on board with the sharing of this data. Of course, we also thank the organizing team, who I'll introduce formally later in this presentation, and all of the participants here and the people who are watching, and hopefully we'll be able to get a copy of this presentation so we can share it on our website so they can see what we talk about here, so it's not a secret. And also, of course, for the NeurIPS competition chairs who've agreed to host this competition at the 2025 NeurIPS. So, based on the people I see in the crowd, I think most people are fairly familiar with the competition. But just for the people who are less familiar with histopathology, how many people in the room are actively working with histopathology images in their research lab? Looks like basically everybody here, almost everybody here. Well, for the people who might be watching, histopathology is a basis for all cancer diagnosis. So in order to get a formal diagnosis, tissue needs to be obtained either by a biopsy or resection. That tissue is then processed so that we can look at it on a slide. Without that diagnosis, then it's not known what exact treatment protocol a patient should undergo, and then we do other ancillary tests to further process that tissue. But the important thing, the histopathology is it's basically the most important aspect of cancer treatment, is getting the right diagnosis. Modern AI techniques recently have been developed using self-supervised learning to create these so-called pathology foundation models. I'll talk to you about the positives and the negatives of that. The reason for this competition is that all of these different pathology foundation models have been trained in different ways. So what we seek to do here is to isolate just the self-supervised learning training aspect of the model to understand what self-supervised techniques actually enhance the performance of these large pathology foundation models. Okay, so let me just introduce the organizers formally. So we have 6 institutions who are participating and providing support and data for this competition. It's housed at Memorial Sloan Kettering, which is my institution. We also have great partnerships with Mount Sinai, with MD Anderson, Mayo Clinic, and then Stony Brook and UNC are providing, they're sharing together on the data and the curation aspect. And our group comes from all different backgrounds. So this is me and Neeraj up here from MSK. Ruchika is here in person. She'll be speaking later. And Gabriele is the PI. I also work very closely with him on other projects. Dr. Jia Wu from MD Anderson is the PI from MD Anderson. We have Rukhmini and Mohammed who will be joining us later today. And then we also have, excellently, we have a pathologist and an oncologist who's also providing us guidance on their data sets. Dr. Hamid Tizhoosh is here. He'll be presenting later today. He's a PI from Mayo Clinic. And Sagir is also here. And Wataru is also part of the team. And then this is the group from Stony Brook and UNC. Joel Saltz is the PI, and Kostas is here presenting for their data. We, fortunately, we were able to get together, a few of us, on Friday night for a nice grill out locally. So it was good to see people and socialize with them in person. Okay. The motivation of the competition is that pathology foundational models are trained using self-supervised learning, and it is a legitimate breakthrough in computational pathology. Before foundation models, the different types of encoders were often created poor representations of pathology data. The breakthroughs in self-supervised learning for natural images has been translated over into pathology, and it's really helped improve our ability to do things. So histopathology is a very complicated challenge from a data science perspective, just because of the sheer size of the data that we interact with. So a single histopathology image is often on the order of 100,000 pixel by 100,000 pixels. That means that compressed, they're 1.3 gigabyte sized images. So you have huge memory requirements just to store them. So at MSK, we have on the order of 10 million of these whole slide images, which means that we require on the order of 10 petabytes of data storage to store those images. So that's a challenge and a cost. It's also very computationally expensive to process them because of their size. There's also a lot of pixels that are background pixels, so you have to make sure that you're only looking at the pixels of relevance, not the white space on the outer parts. And even more complex is that we very infrequently have pixel level labels. Instead, we get reports, pathology reports, that basically are a summary of all the slides for a given case. So you might have a dozen or more of these large whole slide images that are summarized in a single report that might only be a few sentences. So in order to train models at the slide level or the case level, you have to, you essentially have weak labels across the entire large case, we'll say. So the types of labels we interact with are whether mutations are present, whether the patient responded to therapy or not, or maybe something like survival. Those are the types of challenges that we look at. So to deal with these very large images, we break them down into tiles that are manageable for our computational systems, traditionally on the order of around 200 by 200 pixels each. Those small tiles are then batch processed at the slide level. And in order to extract the information from the given tiles, that's where the foundation models come in. So the foundation models basically take these small images and convert them into feature vectors, and then you get a set of feature vectors that represent the entire whole slide image. So there's been many highly publicized, high impact factor journal publications regarding these foundation models. This is Uni from Harvard, Faisal Mahmoud's group. This is the Microsoft group, GigaPath, which was published in Nature. We have, this is Chief, which is another Harvard group published in Nature. We also have the Page AI publication, which Chris was involved with that effort. Chris is here. This is the Virchow and Virchow 2 models. And there's many others, but just to name a few. So once you have extracted the tiles, you have these feature vectors, and then there's often an aggregation level model. So often we use multiple instance learning. And what we've seen with foundation models is that relative, let's just say to the green area, which is more of a traditional encoder, a foundation model often has quite a bit improved performance across many different tasks. So these are the slide level and patch level tasks. This is from the Uni paper in Nature Medicine. However, despite these foundation models being a huge step forward from before, we think that, and I think it's pretty clear that the performance of these foundation models have reached a local maximum, that we're not seeing dramatically increased performance with dramatically increased training or model size. This is a summary from a publication which is a joint publication with Mount Sinai and MSK with Dr. Campanella as the lead. It's a summary of all the different foundation models. This is fairly up to date. We published about a year ago, and there hasn't really been a lot of innovation since then. You can see that there's on the order of dozens of them, more that are less well known, and they have more or less settled on Dino v2 as being the major training mechanism, a self-supervised learning mechanism. So the goal will be to perform better than Dino, as that's more or less the baseline in this competition. But it's really hard to know what's leading to better performance between the different foundation models, if there is better performance, because each institution or company is building their own foundation model, and they have their own bespoke data sets of various sizes. So you can see that the C-trans path was trained with 16 million images, and then the training goes all the way up to 3 billion images that were trained on. But as the best baseline for this competition, I would say, is UNI, because they trained on approximately 100 million tiles. And UNI basically is on par with models that are trained with even larger data sets. But you can see, despite there being lots of differences in the size of the models, the training sets, and the amount of data that's used, the performance on clinical slide level tasks are really plateaued. They kind of all have a similar. There's no outlier in terms of performance. This is a task of detecting breast cancer. This is a task of predicting EGFR mutations. On EGFR mutations, it does look like maybe some of the larger models do a little bit better, but there's also large models that do less well. UNI does fairly well for its size, but again, the confidence interval is large. These are 20-fold cross-validation whiskers. So there's no model that's really outperforming the other, and it's largely because, again, they're all mostly using the same techniques of Dyno V2. So in order to better understand what self-supervised learning techniques actually improve performance, we wanted to give researchers the opportunity to standardize the training data set, and then we're also standardizing the evaluation. So we want to understand which self-supervised learning techniques actually improve downstream task performance. So the data set is approximately 65 terabytes total. This is 300 million tiles. They are curated from approximately 80,000 unique slides. Some of the slides are public, and some of them are MSK specific. Every single slide we use actually contains cancer, although not every tile contains cancer. So there will be non-cancer tiles, but for the most part, you're going to have a very large enrichment of cancer tiles relative to if you just went to your local institution's data set and started pulling tiles. As far as sharing goes, the data from TCGA and CPTAC has been shared with all of the participants. That was, I think we finished that around mid-October, that we were able to get that into the hands of participants. Our original goal was to actually have the competition completed by today, but what we found was getting the contracts for the private data completed in an orderly manner and time was long. It was delayed dramatically. So we're currently at the point where everybody who is an academic registrant has. Oops, I don't know if I skipped that. Well, I'll just stay here. I guess I should have said that here. Everybody who's an academic registrant, the contract has been sent to your institution, so your institution still needs to finish the contract, send it back to us. As soon as we have that signed contract, then the data is available to download from AWS. But everybody should have the TCGA/CBTAC and some other data that's not part of the DTA that they can download and at least start writing their pipelines and making sure everything's working. Okay, now the evaluation, which will be performed after everybody sends in their models, will be done 100% on whole slide images. There's tasks with data from 5 institutions with 30 what we consider to be clinically useful tasks. The evaluation involves over 30,000 whole slide images. The evaluation task data is not shared just because for legal reasons it's basically impossible to share whole slide images. But we will test everybody's model just the same, so it'll be very standardized. So as far as participants go, we have 38 academic teams who have registered. Across those teams, there's 170 members, and these teams represent 6 countries. Okay, so this is what I was talking about before. Everybody should have the DTA in the hands of their legal department. If you contact your legal department and they don't know what you're talking about, please email me right away, and I'll make sure that they move quickly. And as I mentioned, people can currently download all the data by AWS, and everybody will receive the data soon. So the timeline has been extended a few times because of these challenges. What we've currently decided on is not setting a deadline until we know that everybody's gotten their DTA. So as soon as the last team who plans to submit a model has completed the DTA and receives the data, then we'll start the clock of 60 days. And then your checkpoints will be due in 60 days. And then we will coordinate the evaluation of all those models within 60 days after that. And all of the results will be posted on our website. And we'll update the website so it's current in the next few days so that everybody's on the same page as to where we are. And at the end of the competition, we will be sharing the results on a nice website that I helped build. So we're looking forward to that. Does anybody have any questions? I know this is probably what people are most interested in who are participants. Hopefully this is all clear. We wish that everything was moving very smoothly, but with patient data, it's always a challenge. Does anybody have any questions before we move forward? Go ahead. So the way that the data transfer agreement is written is for the challenge. Our intention is to maintain the DTA past the competition, but just to make sure that our legal department is moving on the current thing, we'll move forward on that once that's all been handled. We would like, ideal situation would be that we find a way to share this more broadly, but we can't really say anything for sure. But definitely for the participants, when possible, we'll try to maintain the relationship so that you can keep the data and make sure and keep using it for projects related to this. Yeah. Okay, that's the end of my talk. Thank you so much. Greg's going to give us quick words about people who are positions we have available in our lab.
Hi, thank you for giving me the opportunity to briefly speak, and thank you everyone who's participating in this contest. This is a very exciting scientific area, and I just wanted to say a few words about our vision for how AI will become part of precision oncology at MSK, and kind of get you all excited for this contest. We at MSK have a vision for building an AI diagnostic service. And kind of the idea behind my lab is that we have an AI diagnostic factory where we develop AI tools and the software surrounding them, the deployment architecture, and deploy them, work with the clinicians to get feedback on working with these AIs and in a sort of end-to-end process. So a little bit about AI-driven precision oncology. So AI runs on talent, data, and in my mind also deployment. So you all are the talent, you're coming up with the algorithms, and you're finding out the solutions to solve real-world clinical problems. But I really do think that if you want to take it to the next level, we need to bring things to the clinic, and we need to discover what problems there are when things hit the real world. And so we've been really focusing on this. We think that there will be an AI diagnostic service in the near future, similar to other subfields of pathology. And we're building the infrastructure for developing, testing, and clinically deploying clinical AI tools. We aim to support clinicians with real-time clinical diagnostic tools, accelerate translational research, and build enterprise-level platforms aligned with MSK's mission. In terms of data that we're bringing together, we have, of course, the digital pathology data, which you know about. We have over 10 million slides that have been digitized at MSK. We also have perhaps some of the world's best data sets in terms of liquid specimens, hematopathology, and cytology. And this really gives you a lot of data about the phenotype of the tumor microenvironment, which is very useful for understanding and staging these cancers. The other things that are very interesting and useful to know are genotype. And so MSK is a leader in terms of sequencing basically every tumor that comes into the hospital, often multiple times. And so that genotype data is paired with phenotype data. And really the reason you'd like to pair genotype and phenotype is because you want to predict outcomes, and outcomes in a clinically relevant context. And so MSK, because of the genotyping that it does, is a major clinical trial center globally for cancer. And so if you want to know, if you want to produce predictive biomarkers for new and emerging therapeutics, you really need that sort of data. And surrounding all of that, we've been building within our department the OncoVault, which is LLM-enhanced data curation tool that allows you to in a more accelerated state, create cohorts that allow you to ask more complex questions with more cases, more slides, and more data integrated together. So we're recruiting machine learning scientists, postdocs, and other positions. Of course, you know Dr. Vanderbilt here. He's a principal investigator at the Warren Alpert Center of Computational Pathology. He's an expert in algorithms for SSL and tissue pathology and molecular diagnostics. And also his great work on end-to-end lung cancer diagnostics was recently published in Nature Medicine. I direct AI in computational hematopathology. My specialty is in liquid specimens, specifically blood, bone marrow aspirate, cytology, and then also building LLM-based tools that can assist us in sort of the data processing beforehand. So if you are interested, email Dr. Vanderbilt at vanderbc@mskcc.org. And we also have some paper flyers if you'd like. You can come talk to him, you can come talk to me, you can talk to Dr. Kumar. And thank you for your time.
Thank you, Greg. I'm excited to introduce Dr. Christopher Kanan, who is a tenured associate professor of computer science at University of Rochester. He has been in the field for over 20 years. And he focuses on developing deep learning systems and that advance the foundational capabilities necessary for artificial general intelligence. I've known Chris for at least 5 years, maybe 6 years, from when we met within the Page ecosystem. 6, 7 years, yeah. Yeah, so maybe 7, yeah. So we met through the Page team, working as consultants in that effort, and we've kept in touch over the years. I've seen some amazing presentations by Chris over the years. He's going to talk to us about real-world implementations of models like what we're trying to develop through this competition. We welcome Chris to come speak right now. Thank you. Let's see, you have HDMI?
Yeah, HDMI.
Let's just, yeah, I'll hold this one off. Do you have any audio?
No, I don't have any audio. I do have that. $8, man. Like, why? No, I do not. Get this out of my pocket. All right, things look like they're working. That is good. So hi, everybody. I'm Chris. And thank you, Chad, and the organizers for inviting me to speak here. So I gave this talk about a year and a half ago that Chad saw, and he said, hey, can you do a version of that talk for this workshop? And I'm like, sure, I just use all my old slides. And then I started looking at my old slides and thought, I got to update all this stuff. And so whenever I finally got to NeurIPS, because my son turned 1, and so my wife didn't want me to leave until on Friday, so I wasn't allowed to leave until Saturday morning. And then I sequestered myself to update all these slides. And I still got to do another talk later today, and those slides haven't been touched because you were first. So anyways, so I got 1 hour to do them, and I spent probably 12 hours working on this. Anyways, it's too long. So let's get started. So Greg's vision is the one I would sell people at Page to hire them. And I was so optimistic. And so please don't get beaten down by me. I don't want you to lose your enthusiasm, but I'm just talking about my life, my experiences. Okay, so let's see, does this thing work? Maybe I gotta click on it. There we go. Okay, formally disclosures. So, I led AI R&D at Page for 3 years. These talks are heavily informed by those experiences. And what I learned is there's a massive gap between what we do in academia and even what is in medical AI papers today versus what you need to reach a clinical reality to actually impact patients. I served on Page's scientific advisory board until 2025. I assume they never told me I was kicked off. But as you can see, Page was acquired by Tempus for $81 million after raising $241 million, which means I get to take a very large capital gains deduction this year. So because all my, the government claimed I made a lot of money on those whenever I had to exercise my stock options to leave. So I need to find something to sell before the end of the year. So anyways, let's continue. Oh, wait, well, sorry, I'm using a little thing I've not used before. But this is what we did. So we received the first ever FDA approval for AI product in digital pathology. Great, this took a lot of work. Actually, the AI part, like getting the AI to meet the product requirements, didn't take as long as like getting the study done and all that stuff, but COVID happened, so that was kind of an obstacle. Like the actual R&D to actually reach the clinical requirements took me in a very tiny, small team, which I basically treated as my students, maybe 6 to 7 months, but then leveling up the code to make it kind of production strength and all that stuff took a while longer. Doing the study took a very long time. Going to the FDA took a very, very long time. But there are also a lot of other problems, but we're not going to talk about any of those problems. We're just going to focus on the broader problems. If anybody knows what I just was talking about, you can ask me later. So this is what we're going to talk about. First, pathology, foundation models for histopathology and beyond. I strongly still believe in the big vision. I think we really can revolutionize things. But a clinical reality check is the next part. So there's often there's a big gap between making your paper and having clinical impact. But not only that, your big paper may be very misleading in terms of the impact it purports. And third, if we get there, I may run out of time. I probably should figure out how to watch the time. Are vision language models the future? Okay, so let's go. So you all, probably know enough about all this stuff that I won't bother you with too much of this, but maybe this slide is relevant because I don't know if Chad fully, so you might say, well, why are you even doing this, everybody? Why do we even use the images, right? The images are just expressions of the genetic material, which turns into proteins, and we take photos of that stuff after staining it. Why don't we just use that? Well, then we could probably do this all better, right? A little better, right? Predict treatment response, facilitate drug recommendations, determine the best course of care for the patient. Everything Greg wants to do. Sorry, Greg, I've never met you, but I'm just going to do this. So why? Well, this is why. Here's an example paper. They characterized the transcriptomes in 92,000 single cells. Sounds like a lot of data, right? 15 patients. 15 patients, 3 pre-treatment, 12 post-treatment. You can't train a model on this. You imagine the kind of covariates you have to deal with. Your model's going to just be predicting garbage. You know, it's not going to work. This is not an anomaly. Most omics papers kind of have this small sample size, unlike imaging. And places like MSK are one of the rare places where they actually do gather a lot of that kind of data, plus the images, which can really democratize it, because they do MSK impact pretty routinely. So omics in general can't scale, but histopathology can. And I think that is one of the major outcomes I think this workshop has the potential to really kind of articulate. So if you weren't clear, why are we predicting EGFR from H&E? What's the point here? So this is a good reason why. Omics can't really scale on its own, right? But you're lucky to have this matched data. Okay. So I have some experience doing this foundation model stuff. So even though I'm like the a middle author in there or something. This was my pet project for a long time at Page. Starting in 2019, before we even had the term foundation models, I was selling new recruits on pan-cancer models. And my dream for creating a pan-cancer feature extractor we could use for everywhere, right? It seemed made logical sense. I promised myself I wouldn't do anything too political. I can say that a lot of people internally had a lot of trouble wrapping their minds around this notion because it didn't match traditional like product definitions. You have a team per tissue type, not a build a big feature extractor and then have lightweight teams that can use it, right? So that there was a huge mismatch. And actually some of my friends at Path AI, I've made friends since post-leaving Page, they're like, yeah, we had the same problem. Like it was hard for the AI people to convince other people of correct strategies. But anyways, that's a tale for another day. Let me focus on the broader stuff. Anyways, this is the thing, you know, you guys all know this stuff right now, right? Chop it up into tiles, train a self-supervised model, extract embeddings, do fun things. You can do traditional things like pan-cancer detection, subtyping, digital biomarker prediction, right? That's the real exciting stuff. Verkov was trained with, as we heard, Dino V2. All of them are trained with Dino V2. I keep thinking, I hope some of you competition people trained with Dino V3. Let's see what happens. You know, we got the new version out. You know, 1.5 million H&E whole slide images, 38% of cancers, blah, blah, blah. We all know this. Trained with tiles. I didn't know everybody would basically be in this community, so this is just recap. I'm going to skip it. Works great, okay. Effective on data across hospitals, blah, blah, blah. You guys all know this. We got biomarkers too, and hey, it was state of the art compared to other things that it was compared against. Of course, how else are you going to publish it? And look at those AUCs. Those AUCs are great, right? We'll come back to that. But so about how that really isn't sufficient for actually having clinical impact. I promised my students, since he knew I was giving this talk, I would advertise his paper, so I have to do that. So I felt like this was a segue. I gave ChatGPT my slides and said, cut this. So I said, but my poor student. Anyway, so I dabbled in one pathology paper since leaving Page 4 years ago. Anyways, that's this one. It's a project that I had in my head while there, but you know, nobody cared. But the idea is, can we build an architecture with an inductive bias for explainability, right? Because what Page's systems all basically trained in a weakly labeled manner from the best pathologists in the world at MSK, and then as an emergent phenomenon, you can do a bunch of post-processing and get a heat map. Why don't we actually have heat maps as an inductive bias internally into the model, such that it builds a heat map internally and then uses it to make the prediction. And so you basically get that for free. We tried it out with Uni and Verkov too. And hey, the AUCs are about the same for different aggregators. Aggregators are the thing that ingests all the tile embeddings, right? But look at that semantic segmentation score. Big jump, right? So that was the goal, right? So for weakly labeled semantic segmentation. Anyways, if you're curious, oh yeah, the pathologists like this. They said, whoa, this looks really good. So that doesn't look like much. But then whenever you zoomed in, at least the pathologist that looked at it said that was really good compared to other models. I'm not a pathologist. I can't really tell you. So anyways, if you're curious, check it out. We're proud of it. My student took a photo with Faisal Mahmood, who is also, I guess, excited whenever he presented the workshop paper. Or not workshop paper, conference paper. Okay. So moving on, what else can we do with them besides, train aggregators and make these predictions like just with classifiers? Well, we can hook them up to a large language model. Now we're talking. Now we're building the ChatGPT for pathology, right? Here we did this in Prism, which is just, I think, an archive preprint. But basically, Page has access to, Tempest has access to all the data from, I don't know what the deal is anymore. I don't know how that's all going to play out. But anyways, the pathologist notes, why don't we train from slides to pathologist note? And so that's the idea. Have Verkov provide embeddings, have the LM ingest the embeddings, and produce pathologist note. Sound great, right? And look, generated caption in invasive ductal carcinoma, well differentiated with positive estrogen and progesterone receptors. And anecdotally, Page's consultant breast pathologist, Chad was our consultant molecular pathologist. So the story I was told anecdotally was that whenever he had saw these results, he started shaking. He was so excited. He's like, the model did this? So it seemed like a very big deal to him. But it's hard for me to get as excited. Okay, but anyways, these are just examples. That's not the focus of this talk. Not here to talk about Tempus's foundation model. I did have to advertise my students thing, my one post-page thing. The many groups have created, as Chad pointed out, foundation models. They work looking kind of similarly. On some, incidentally, if you look at some of the papers where they test them in like on robustness tests, and what you'll find is some of them perform kind of very differently in kind of like tougher situations. But anyways, so patients will benefit, right? Right? Okay. So again, I just don't want to put anybody down. I think this is great. I think this is a great mission. So I stuck this slide in here, right? So this workshop, I think, the goals here, I'm sorry, Chad, to hear about all the legal issues. I was thinking I should get that data set. And oh God, how am I going to do that? University of Rochester's legal is terrible. Terribly long for things. Anyways, but so I think we really could create better systems, but what's needed to turn that into real-world patient impact? Right? Academic foundation model, patients benefit, right? Okay. Well, what do? Well, you guys did not do this. You used the dataset, competition data sets, but we still use like metrics like AUC to assess performance in a lot of papers. You saw them, Verkov was doing it, and you should use AUC. But does AUC kind of suffice? Let's look at UNI. So no criticism to UNI's paper, but it's something everybody does. I'm just going to use this as an example. I'm not criticizing the paper. Recall an AUC curve. So sometimes people just start doing metrics without thinking, what is the metric? What does it mean? You know what it means, but you're not thinking about it anymore, right? It's a threshold agnostic measure because you thought it's too hard to pick a threshold. So I'm going to integrate under it and have a score. Works great for tuning things. But what if your system's at, and this really happened to us at Page, where we did not meet the criteria for the FDA, and our AUCs of our Page prostate system were, 99.99. There was something, because the FDA was not asking us to assess ROC curves. They said, pick a threshold that works across all these data distributions. So you end up with a predicament. Okay, so there's UNI. We talked about that earlier. I used it, some embeddings, it works great. Verkov 2 was a little better, of course, but it was trained on a lot more data. And it came later, right? The new thing is always better. Okay, so here's their AUC scores, right? They compared against the other state-of-the-art at the time, right? Looks very good. There's the curves. You even got to zoom in on them, right? They got the inset. Works way better than ImageNet 50. Let's hope so, right? Otherwise, we really wasted a lot of time. So then they thresholded it in the paper, and I'm happy they did this because this gave me a very useful slide. Okay, so they went from these AUCs, which are, 0.9776, or 0.976, to pan-cancer classification. Now we're at 75%. What the hell happened? Well, each ROC curve was generated independently. They didn't have a universal threshold, and so these really aren't. Like you can see the AUCs underneath with the accuracy, right? There's a huge gap, right? You probably thought 0.97 AUC, gonna have perfect performance, right? Barely any errors. And hey, I gave the first version of this talk. Gabriele, the first author on this paper, was my chair and introduced me. So I'm like, Gabriele, please don't get mad. But I'm like, you're the next example, okay? And Thomas, don't get mad, so back there. Okay. So good enough to found a company in 2018, right? So Nature Medicine. This was the paper that served to found Page, and they had great ROC curves, right? So in distribution 0.991 out of distribution, 0.932. That was actually my first task, figure out how to fix that. Which didn't take too long. Okay, so this was kind of like the big gap that I had to solve once we threshold the thing. So instead of looking at AUCs, let's threshold the thing. And here it's thresholded at a false positive rate at 98% true positive rate. Okay? And so the purple's page, and the gray is that Nature Medicine paper. And you can see, like, especially on the middle distribution, which is the one we needed to work on because that was the FDA-cleared system, at that threshold, the false positive rate was over 50%, right? We had to bring down that thing to actually get it to be clinical grade. But anyways, AUC, I know it's kind of silly to talk about AUC so much, but I see it in all these papers, but nobody thinks about actually defining metrics around the intended use of the system. We just, you do threshold sweeps, and the same classifier, just as an example here, I'll give you an example in a couple slides. Same class could have high AUC on multiple distributions because you independently swept it, right? You took one classifier, and you ran it on 2 data sets, and then you check 2 test data sets, and you check the AUC on both, and they're both 0.98 or something great, right? And you're like, great, everything's great. It works well on both, right? Okay, I need to pick a threshold. Do you think you're going to find a threshold that works on both data sets? Maybe not. Maybe very, 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 very different threshold that works on one versus the other. So anyways, this was, at least with the FDA, they needed us to have universal thresholds across distributions. Here's an example of this. So here's, basically this is created by kind of like somebody saying, this is our minimum bar for our specificity and our sensitivity, and so we need it to be within this range, right? You must have a sensitivity of at least this and a specificity of at least that, right? And then we're just showing the F1 score and just plotting which thresholds for each of these distributions where one of the curves is the combination data set, do we meet that criterion? And you can see, those all look quite different, right? So this actually this was one of Paige's big things I had to deal with because, the literature is terrible about this. There's very little papers about how do you pick a threshold? You'll find this one like medical AI paper saying, this is a rock curve. Pick the point, right? But look, you can't. You gotta, so basically what the trick is, do something like this, pick the intersection of the 3 curves. But if none of the curves intersect, you're in trouble, right? Anyways, I keep thinking I should write a paper about this. Like, it's so simple, but it's like, there's nothing out there on that, at least last I checked. So this is called acceptance criteria. I learned this through product managers. I just was an academic AI person, right? I mean, I learned way too much at Paige about distributed training, managing people, managing teams, talking to VCs, talking to boards, politics, and acceptance criteria. So I learned a lot. But acceptance criteria specify when a product has achieved a clinical grade performance for its intended usage. For classification, we need a fixed operating point, like, for example, sensitivity greater than 97%, specificity greater than 85%. Must be satisfied across all relevant distributions, and at least for Paige, this involved kind of like going to the FDA and saying, what about this? And they'd say yes or no. They do not tell you what they want. They just tell you yes or no, that we don't want that, They won't, well, what should we do? They won't tell you that. Anyways, but AUC is an acceptance criteria. But I worked a lot with pathologists, like there's Patricia Rossetti, Chad, and others, in order to figure out what are these things. And, as an AI person, I had, the other thing that I found really hard for a lot of AI scientists was to really respect the clinician's opinion, right? They thought, I know best. I didn't know best. I don't know what's right and wrong. The ground truth might not even be right, right? I need to sit there with somebody and say, teach me what you know. Let's develop a shared vocabulary. And in fact, I think they need more training programs along that line, right? Because you have to speak both languages. Defining acceptance criteria is hard. So you kind of got to start with the intended use, who's going to use the model, for which decision, what happens when it's wrong. Talk to clinicians, but keep the buyer in mind. We'll talk about why that matters in a bit. Okay, define metrics, intended use, enumerate your edge cases for robustness tests. And again, we had help from the FDA to do this because we got, I forget what it's called, you know, some early thing where we just get to talk to them more. Then you got to get all this data that you may have trouble getting. Fortunately for this competition, you actually got a lot of it. But you got to get data from other hospitals, data from other scanners. What about rare variants of the disease? One of the things they asked us for our Page prostate system was, how well does it work on foamy prostate cancer? And, you know, what I was told by our pathologist was, I know what it is, but I've never seen it. You know, it's like, okay, it's really, 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 really rare, you know? So you can't expect to do everything, right? But you know, the FDA may think. But anyways, most medical AI papers like just show you an AUC curve. They may have a thing where they're running the same system, multiple data sets, but then running an AUC on multiple data sets is really going to be very misleading. Pick an operating point, show me that it works well across all of them, okay? But this is another big challenge just for developing these things. This is just, you know, talking about uncertainty. But you know, we often lack the data we might need, right? Like the FDA is like, hey, do foamy prostate cancer. What if they made us? We're like, well, where are we gonna get this? We have MSK, they got all the data, right? Must be somewhere in there. Parse the free text. Parse the free LLMs, right? I don't know. Maybe there's been somebody somewhere once upon a time. Did they scan that guy yet? You know, and even then, what would we have? Sample size of 3, 4? I don't know. It would be small, right? Super rare. But even then, defining acceptance criteria was iterative. Almost surely, you will mess it up at first. The definition and the data will change. Now, if anybody, so I teach it now a class based on my experience with the page. One thing I'll tell everybody is, don't just go changing your labels, right? You version your data sets, you version everything, including your data sets. Don't just make a new version, right? You version everything. This is the ML ops. I wouldn't have said this pre-page, or pre-page. I wouldn't have done any like I got all this stuff in my head. Anyways, you got to deal with all this. Okay, we did it. Time to celebrate. Clinical impact, here we come. Right? Clinical impact, here we come. Your AI is clinical grade pathology models, can democratize access to best expertise, provide universal second opinions, enable faster diagnosis, and my dream is facilitate precision medicine, right? Really, really do these great things. Okay, great. So let's assume you do this. Let's assume you get those things to work as well as Chad was saying we plateaued. What if you break all those plateaus? You're going to have impact? Okay, so at some places where they already have all this infrastructure, yes. What do you need to do the AI? Well, hospitals get to use that after they buy some scanners, hire some people to scan, and store all those digital slides. And I'm sorry, this has nothing to do with AI, but this is the reality, and it kind of hits you in the face whenever, you know, you got to take your large capital gains deduction. Okay? How much does this cost? Okay. Daily volume of 1,000 slides per day for a regional hospital, not MSK. They're way bigger. They're already digital, everything, right? Okay. We need at least 3 high-volume scanners. They'll sell you those for about $300K up front. There's more competition now, so I try to get some estimates. This is what I spent way too long doing, figuring this out. I don't know why I decided to do this, but you know, okay. Plus, they'll make you do this: an annual service contract of about $100,000 a year for those 3 scanners. So now you got to do that. That'll last you 5 years. See somebody shaking their head. I don't know if that's because this is wrong or because they're so disappointed, but you let me know. This is just what I found online. Okay. But it all is consistent. Like I gave this version of this talk like a year and a half ago, but I was like just kind of like not putting numbers with things. I was just saying this has been my experience, but it's like, but I didn't have the numbers that the hospital must have worked through every time they said no, thank you. Okay, so now we need at least 2 FTEs for this digital pathology imaging technicians with benefits. Those are about $70,000 a year. Great. So now I'm working, 8 hours a day scanning, maybe on 3, I don't know. 70,000 might be at the low end, probably depends on where. Okay, what about the storage? So each whole slide image, so they vary in size, especially with the 40x scanners. Chad said 1.5 gigabytes. I don't know. I got 3 gigabytes. I don't know what's accurate. But anyways, it doesn't matter. Same. We're talking about orders of magnitude here. One's 2x more or something. Anyways, but regardless, let's assume about 1 petabyte. I had to make a bunch of assumptions. 1 petabyte annually for this regional hospital, right? Not MSK. They're making probably way more data. Okay? Okay. So here are these plots I try to come up with. Annual cost, millions of dollars for doing this, including hidden costs. Whereas I spent, again, I should not have been doing this yesterday, way too much time learning about IT chargebacks and how, you just try to actually, I'm like, instead of actually just paying AWS, which already sounds like a lot, your IT department will put a bunch of overhead on you for some reason. And I don't fully understand why, but it doesn't matter. Anyways, I learned about this. Okay, so this is what the hospital now sees. Great. You see that green curve? This is kind of like with some generous assumptions. Pathologist gets 12% more efficient, this and that and this, right? I was trying to be generous. Hospital sees negative 4.3 million deficit. And, with a cumulative of about 17 million over 10 years. Great. We had a lot of trouble selling. The price for the clinical benefits are hard to monetize, right? Reduced errors, mistakes made by pathologists, they're human. Barcoding, mistakes, lost slides, these things happen. We get faster turnaround time, all these things, right? Happier pathologists. Pathologists don't buy your product. So, somebody else does. So how do we shift the calculus? So then this is the real thing, right? If you want to make all that stuff help people, so you still got to build it, right? But how are you going to get people to actually use it? Well, the hospitals aren't going to use it unless it makes money, or at least breaks even, right? Or for some reason they feel shame because everybody else doesn't want to go to their hospital or something because they're so outdated, right? But anyways, if a new blockbuster drug required a diagnostic test that would only be done with AI on a whole slide image, then that would shift the digital pathology from an operational cost to revenue generating clinical necessity. And then again, spending too much time on this, needed to be about $400 per test net profit for the hospital to start looking like a pretty good investment. But if somebody can do that, then now hospitals are like, we better buy some scanners. Anyway, so this is just sad, right? I mean, you thought I was going to talk about foundation models and stuff, but this is just like lived experience, trying to say, well, my idealistic AI mind, and then meets the real world. Okay, so I don't know how much time I have left, Chad. I'm going to shift to topics for a second. 5 minutes. Okay, great. I don't need much time. Okay, so I'm sorry if I depressed anybody, but this is just the reality of it. Just trying to build a business in this space is very hard. And then there was a ton of competitors too, right? So you had now you're like competing. You got to convince them to go digital. Plus, then they're like, well, what's the cheapest AI product? Well, we went through the FDA. Well, so okay. So anyways, okay. So remember Prism? So okay. So say those are just market things. Let's think longer term, don't worry. Somebody will figure out a way to make it all digital. Everybody agrees it's the future. It's just, when is the future, right? So let's just focus on building the future, right? We'll worry about, leave that other stuff to other people, right? Vision language models are the future, right? Well, that's what we'll do. Vision language models, like Prism. This is an LM, everybody knows this, right? Feed in language tokens, right? Which are substrings or little pieces of text that turns into little vectors, right? You'll see why this is it's some initial context. We're going to get to why this is relevant here. Okay, so then you might say, okay, we're going to build these things. So if anybody knows, nowadays we all use reasoning LMs, right? You put on thinking mode, right? Gets way better, way better. I'm going to oversimplify. There are different strategies. Who knows what OpenAI and these companies do anymore, because they're not open. But basically, you think of it as iteratively talking to itself and refining and spinning out additional models to talk to itself, summarize that, and decide, was that a good idea, was that a bad idea, whatever. But it's talking to itself like a big, big, big internal monologue in language. Okay. And then you're like, okay, so how do I make it a vision language model? Well, the way we do that is we pre-train an LM, and again, most of you already know this, but I'm just, for context, Pre-train a big LM, pre-train a big vision encoder, like a self-supervised foundation model for pathology. Have a projection layer that projects the embeddings from the vision into the language and treat them as substrings, vector substrings. Great, okay, so we're gonna do that. And it all seems to work great. So, here's an idealized scenario, right? We got our vision language model, and it's talking to itself, reasoning about what it should do. Great, let's see what ChatGPT does. Okay, so that's idealized. So I put in 4 images and gave it to ChatGPT, and I numbered them, and I put them in different orders. Originally, there was one big, it's for a tutorial for pathologists. So I chopped them up into individual images, numbered them, and removed what they are. So these are all from human breast tissue. Okay, please reason about these human breast tissue samples, determine the form of disease, and I put it on to standard thinking. If any in each of them, and give your justification, please put them in order of severity. Not neoplastic would be least severe. Image 22, closest to benign lobules. So this was very, very, very wrong. I actually had a pathologist check this for me, because I'm like, I think this is wrong, but I just didn't want to embarrass myself, so I actually had a pathologist look at this stuff for me. This next one, it said this is the second worst, or second least bad. Wrong. Not very wrong, but at least wrong. Wrong. Hey, got invasive carcinoma right. Good job. It looks so different, I could get this right. I spent enough time at Page to know what this is bad. Okay? So then I said, oh, here's what they are. How'd you do? Call it 1 out of 4 on exact labels, 1 out of 1 on which one is clearly invasive, and the rest wrong. I got 9 as invasive, and it's really proud that it seems to like I'm anthropomorphizing. It's like, I got that one right. I got that right. But it does acknowledge it got DCIS way wrong. Way wrong. So but it knows what they are. It knew how badly it messed up. But it can't reason in words to put these things to severity, because do pathologists reason in words? Do you look at the slides and reason about them with your words? Or do you use your eyes and your brain, your visual system? So I'd argue, again, this is a little side thing, but there's something I've been thinking about in my head, and I don't work as much in this space anymore, so I just thought I'd throw it out there. Kind of got a linguistic bottleneck. But I think this is just more broadly than just the pathology stuff. I think this is more general. But we have mismatched architecture, right? And even in humans, you may think, if you're somebody with a strong monologue in your head, there's been lots of cognitive science studies. Language is a means of communication. It is not a means, it's not your primary mode of thinking. You have the ability to think about things visually and spatially in many other ways. And if you think you only think in language, then you think every other animal doesn't think at all. And I think that's pretty false. Anyways, so I would say LLMs are a bottleneck today as they're built, right? Vision language models pass images to LLM, then we do our thinking in words. And so I think this is kind of like not right. What if the thinking was visual? What if the vision encoder, not the LLM, built internal representation assemblies? Instead of converting images to words to decisions, the model goes images to biological states to decisions. The LLM could become like an optional thing that inject context, not the brain thinker. Yeah, so this is just trying to juxtapose what these two look like, rather thinking in words versus thinking visually. Here's a couple more mocked up examples. I used Gemini to make these ones. I was like, can you make me a mock-up like this? It did a really good job. Anyways, this is just boring stuff. It's not very super exciting. It's like, here's some transcriptomics and an H&E. The transcriptomics are supposed to be optional. Here's the instruction, visual chain of thought, reasoning, spatially grounded. Anyways, these are just mock-ups, right? There's no actual paper. But I'm just saying, I think this makes a lot more sense than thinking in words about images. Just FYI, in my opinion. And you saw how bad ChatGPT screwed up. This one's about find me. I came up with this example. We want to repurpose drugs, right? It's really hard to get a drug approved. We want to repurpose it for something, right? So try to figure out which drug we could repurpose for something. This is just a mocked-up example again, just so nobody thinks this actually exists. But anyways, I think it's an exciting kind of direction. Thanks. I really do believe computational pathology has this huge potential. There's just these big bottlenecks. One, the academic papers are just can really mislead you because they're not aimed at the right thing. One of these papers in Nature I actually found out later on was actually just tested on the training data, right? You do self-supervised learning, you can't just go saying, okay, now I'm going to test on my labeled same data, right? You know, I think that one was in Nature, right? Like there are a lot of stuff which is bad science. People should know better. But anyways, you got to think about what is the intended use, design your metrics around that. And I think as a community, we'd be making more progress if we didn't trick ourselves, right? Instead of just, you know, competing for AUCs, because an AUC is not clinically relevant. Your AUC is terrible, it's terrible, right? That doesn't tell you anything. But whenever you get past a certain threshold, you're getting close, AUC no longer is sufficient to really be informative. We've got this adoption challenge, and it's depressing me. But also, I think there's a lot of research opportunities, so thinking about how to make better VLMs. Okay, so anyways, thank you so much.
I think that because that was such an engaging talk, we should give people a chance to ask a question or two, even though we're a little bit behind on time. I did want to mention that based on your talk that I saw a year and a half ago, we, in our recent Nature Medicine paper, we have a very deep analysis of the positive predictive values and negative predictive values.
Oh,
at various
fantastic.
thresholds. So I'd like to just plug that as an analysis. It's figure 4 from our Nature Medicine paper, if you want to check that out.
I gotta look at, I'll try to remember, Chad, but send it to me if I don't. Yeah, I'll send it to me. I now have a student who's interested in this topic, so I was kind of like not working on it very much, besides the page stuff. But now I have a student, so yeah.
Absolutely. Anybody who has questions can come up to the microphone. I think we only have one microphone. So it's
Hello. Hi, Dr. Kanan. Amazing talk. Just quick question about you're describing that we have a problem now selecting a threshold for different data sources, databases. So because I just beginning at the digital pathology world research, and I noticed the same thing where like most papers kind of ignore the fact or if you cluster the feature space across databases, it's very obviously they're recognizing a huge amount of batch effect. Do you think it is because right now our maybe training methods are kind of encouraging this sort of kind of hard memorization between clusters and then narrowing down, I don't know, I'm just having an analogy here. It's kind of like zooming in whatever you remember as this could be the batch effect and then trying to figure out within the batch effect, do you think this is a reason why we couldn't select a universal threshold for all? Do you think this is a direction we could, in the future, maybe in the technical side, try to solve this problem?
It's a good question, right? I mean, so the root cause of the issue behind whether or not a universal threshold is available or not, I think there could be multiple, and it could vary depending a lot, depending on your situation. But if we don't kind of set it up such that we're measuring this kind of thing, then we won't even realize we don't have it, right? It could just be I'll give you an example, right? It could be something about how you're training or regularizing your model that causes you to get these very that makes your thresholds very much disjoint and not have a very small overlapping region. If you were measuring it regularly, then you could be looking at how this affects it, which is exactly what we did at Page whenever we realized, wait a second, we get great, so we basically had to create these, different distributions of basically amount of cancer on a slide, and then if you look at the overall AUC across all of them, it looks great, but then if you chop it up into the little bit of cancer, it looks great. Okay, now pick a threshold. You get very different thresholds for what should be the one with just a few, that was at the time, few tiles of cancer versus more, right? How do we solve that? Well, once we start measuring it, we can start looking at how do things we change during training, heavy data augmentation, affect this property or other things we were doing, right? Yeah. To make the thresholds, overlap more. I mean, some companies have done all sorts of weird stuff, but then they can't get through the FDA to deal with this. We'll tune on all your own data, right? And stuff like that. I mean, but I feel like that's dangerous, right? It's just ignore the FDA.
Yeah. Great. Thank you so much.
You got to measure it to fix it,
Yes. Great. Thank you so much.
Hi, that was a great talk. Thank you. So I know you mentioned that for this specific use case, some thresholded metrics like precision, recall, and specificity are more important. But for me, like, I would think that a model that still also has good performance across multiple thresholds is better than one that has really good performance at one. So I guess my question is that, are there any threshold independent metrics that you would consider also important in conjunction with those thresholded metrics, and how would you rank them in importance?
Gosh, this is a hard question to answer. So, I mean, going to like, again, I can only speak from my own experiences. So, I mean, we can split this question in two ways. One is, we could say, okay, what does the FDA want, or some regulatory agency, and they really want you to choose that threshold. On the other hand, could you choose an entirely different strategy that allows you to do something else, right, besides choose a threshold? Like, I spent a lot of time learning about something called conformal prediction, which was way too hard just because of, it's not hard, but it's just it's made by statisticians. They use words that were harder for me as a machine learning person to, like okay, what do you mean? What do you mean? But anyway, so basically, it rejects the whole notion of a threshold in like as the output, and basically it forms what's called prediction sets instead. So it's an entirely different sort of paradigm that gives you some statistical guarantees as long as an assumption, a strong assumption, is met. But you know, so you could think about like different paradigms instead. But yeah, I agree with you, like that. I would be personally pretty nervous if, you know, if you looked at those little like plots I was showing with like the little curves overlapping, and we saw they overlap, and it's like within this 0.02 range, right? Tiny range. You're like, well, that does not seem like a very robust overlap, right? So yeah, I agree with you in that regard. But I think just the main, so I don't have a better strategy currently besides this. I wish I did. It's like a weird thing, you know, it's like this is like the simplest thing, like the stupidest thing we do, right? Like we just kind of like learn it, and then we're like, do AUC instead. It's kind of hard to pick thresholds. And then, you know, it's like, it's weird, nobody talks about this, but like for a clinical decision support system, you've got to do it. And I don't know, I'm just trying to explain how we did it, and how I dealt with it was just measuring it, right? Figure out, okay, if I want to have impact, what do I need? How good does my system need to be? And on what distributions, data sets, does it need to perform that well? Okay, find them. Run on each of them with the same settings. Does it work? But if you don't measure it, you know, you don't know, right? And if you just look at these summary statistics, you know, AUC or something, you may end up thinking everything's great, and it's not. It's just a weird thing, you know, it's like a thing I've never, ever pre-page even imagined thinking about having to talk about, you know? Like it kind of, but it was like a real crisis mode whenever we had this problem. Yeah, there's lots of weird things that you never would have expected. Like I'll give you, sorry, I'm gonna get sidetracked here. Another story, a brief story that was a big fire there. So we were trying to build this page prostate system, right? And it was getting really high errors on something, right? So this is like a really, I think this is a good story for why, you know, whenever you're doing something like this, you need to train your AI people to understand the medicine, and train your pathologists to understand enough AI, right? And so a lot of times, this is what I teach my students when they really struggle with this. The most important thing you do is stop throwing darts to improve your model. Look at your errors. What are you messing up on? And figure out if there's some label associated with them. Well, we don't have any labels. All we have is cancer, non-cancer. Where did those labels came from? Well, the pathologist gave us a taxonomy. How did they choose that taxonomy? Well, they told us what was cancer, what was non-cancer. What is this? Okay, well, let's look at the finer grain thing. What's an ASAP? Patricia? So this was our pathologist there. And she's like, oh, go blah, 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 blah. We defined them as cancerous. Do you know what ASAP is? It's a pathologist saying, yeah. And so we had them as our ground truth evaluation data as cancer, Or rather, I think it was cancer. It was not cancer. It was benign. But it was, in our evaluation, it was benign. But the pathologist was like, because the pathologist going, yeah. Could be. But it's not big, right? So like, don't worry about it. But what is the AI going to do if it looks like cancer but tiny? Well, you're going to throw huge errors, right? Don't remove it from the test data. But, this is the trick was data-centric AI to improve that problem. It wasn't anything else. It was like figuring out what do we need to do to our training data to fix this problem, right? Because it was literally like there was a mismatch. That's sorry, I know this is like, but this actually helped the reason this reminded me of it is this played a huge role in making those thresholds no longer overlap much better, right? Getting your labels right. Right? Because instead we switched it, right? ASAP should be, it shouldn't be benign. It's cancerous or like, I forget the word, precancerous, right? Or something. I forget something you should look at, right? I mean, it shouldn't have been a cancer, no cancer system. What it should have been, in revision is, should pathologists look at this? Should we show it to them? I mean, that was the right output, right? And so, but you can't get it right the first time, right? You need to iterate. The pathologists get it wrong, you will get it wrong. You gotta interact. Sorry, I don't know if I got sidetracked.
Thank you.
If you go back to the seminal paper from Stanford, and nobody has tried to redefine foundation models after that, so you have to look for zero-shot performance and fine-tunability for downstream tasks to call a model foundation model. But it seems, at least in pathology, foundation model has become a buzzword almost, which will damage all of us. AI people, pathology people, because at the moment the zero shot is below 50%, so it's not zero shot. And many reports are coming in that instead of getting 50,000 whole slide images to fine-tune a gigantic model, you can do a task-specific one which much less, so they are not fine-tunable either. So the question is, again, to the benefit of pathology community and AI community, because we will all of us get damaged because they are not foundation models. I know that's a tough thing to say because I know many colleagues put a lot of work and effort into that. And it's mainly because medical journals are publishing computer science papers, which is a very strange trend because they don't have access to computer science reviewers, and they actually don't solicit it. The cases that I know about, the reviewers of these papers are enthusiastic pathologists, which understandably are accepting that ROC curve is a good thing to measure the performance. So do you agree that, I know that this is a tough thing to say, but actually we still don't have foundation models in histopathology, do we?
I guess, okay, for the reviewer thing, I would say if you did have a computer scientist, I don't think you'd probably be in any better situation. They might get the methods right, but they'll be like, hey, you see, it looks good. Computer scientists, I mean, this is another thing where I've been trying to rethink how AI should be taught, and I'm like, computer scientists are doing this all wrong. I got the max, I bold it, I win. You don't even know computer scientists don't even know how to do hypothesis tests. They don't even know what a covariate is. They're like, I changed 80 things, I'm the winner. I got a new method. So I don't know if computer science, yeah, they should, the AI people should be reviewing them, but I'm just saying, I don't know if it fixes like some of these problems, right? It's almost like, it's just like stuff people don't think about. On the foundation model point, I'll say why it's trickier, and that's mostly because I think the definition of foundation models has kind of changed over the years. If you look at the executive orders, they have a definition, which is like the Biden executive order, the Trump executive order, I assume also has a definition of this. It's like a foundation model is a big neural network trained with at least such number of parameters in the millions with self-supervised learning. They don't have the performance evaluation like the zero-shot thing, but the zero-shot stuff is like, well, okay, well then, it's just a big thing trained with self-supervised learning. Okay. Why'd we do that? Well, the reason is stuff like, the original work for it excelled at zero-shot learning. But I don't even know if zero-shot learning makes sense as a target for, like, because I used to talk to these pharma companies, right? They come with their pitches, and they're like, hey, we want to work with you guys. We got data. We want you to help us develop like a companion diagnostic. We got 30 positive slides from our CROs. They're really dirty. Can you do that for us? I'm like, well, how am I gonna, you have only one. They're like, well, just find others. I'm like, do you know what the model's gonna learn? Hospital versus not hospital. And how am I gonna validate this, right? So the reason I'm bringing this up is like the zero-shot thing. Even if you could do zero-shot learning, why would you do it if you can't validate it, right? What do we need to actually know if it actually works, I guess, right? Like, I think it's a different space, right? I mean, but I take your point about the foundation model. Like, I like just calling them pan-cancer models originally. Like, I would be happy with that, and maybe you would too. Like, it's just like, why should we create a prostate model and a breast model? Why not have a universal model? Self-supervised learning, right? But as far as these other features that foundation models are supposed to buy us, yeah, I don't even know if they make sense for pathology, right? Would you trust a zero-shot learned? How are you going to validate it? I don't know. I'm sorry, I can't really answer this question very effectively, but those are some initial thoughts.
Okay, I think we better move on to our next section. We're a little behind. Thank you so much, Chris. That was very thought-provoking.
Thank you, Dr. Kanan, for a wonderful presentation. Now we'll have participant presentations. Each presentation is about 5 to 7 minutes. The first one is Team Sinha Lab. I think Ananya is going to present from them.
After they speak, they can sit up here so they can ask people questions as a group.
Yeah, so we will take questions after all the participant presentations are done. So all participants, after completing your presentations, please take a seat on the stage so that we can take questions afterwards. Okay, oh, you have it.
If you launch it, it should.
It's not.
Maybe,
Okay, yeah.
there it is. There it is. Perfect.
How do I cannot see it. Oh. What? I'm not able to full screen.
Yeah, but I think you have to actually launch the presentation and it'll go full screen. No, if you just actually start the presentation with your slide thing there, it should show you. Click on
Sorry, that's a wrong presentation. Sorry about that. Hi, everyone. I am Anamika. I am a research assistant in Sinha Lab at Sanford Burnham Prebys here in San Diego. And since we have not started training our model yet, so I'm just going to present some of the limitations that we have observed working with these foundation models for more than a year. So a little bit about my research background. My research lies in the intersection of aging biology, computational pathology, and AI. In our latest paper, we showed that morphological features extracted from the histology slides can naturally segregate young versus old tissues in a lower dimension with no prior training. So building on this, we built a framework to quantify the morphological changes that happen with age. We call this structural aging. Then we also built a framework to predict bulk telomere length from the histology slides as an alternative to expensive molecular assays. So I'm going to skip that. So while working on this, we realized that there is no mouse pathology foundation model. All the models have been trained exclusively on human data and are limited to the clinics. And they cannot be directly applied to the mouse studies, which is more common in research setting. So large volume of mouse pathology data just remains sitting in the lab unanalyzed. Why do we need a mouse pathology model? So in Sinha Lab, one of the things we are interested in learning is to quantify the structural changes which happen whenever an intervention is given, specifically anti-aging intervention, so to study the structural changes with that. So to address this, we are training a mouse pathology foundation model. We are very early in this development and with just the first version of the model trained. We have used Dino V3 as our backbone because it is better at capturing the localized features, which is extremely important in pathology compared to the previous version of Dino. So our backbone is domain-adapted pre-trained Dino V3. We started with a smaller VIT backbone with around 29 million parameters. We have comparatively much smaller data set with just 21,000 whole slide images from which I extracted 17 million patches. Our patch sizes are of 3 different pixel size, 224, 512, and 1024. We also did a mixed resolution batches to expose our model to finer cellular detail as well as coarse architectural context of the tissue. And we introduced augmentation, specifically color jitters, for stain variability that comes from different data cohorts. So we're still very early, and we're testing our model and designing the benchmarking, and also collecting more data set to scale our model to larger VIT backbone. So if you're interested in this, please reach out to us if you have more data or you want to use this model. That was our model, and we wish to use the same architecture for the SLC dataset. The other limitation that we observed was with the VLMs trained on the CLIP architecture. So the CLIP models such as CLIP and Conch, they have image as well as text as input, and there are two different encoders for each. The goal is to align these image embedding as well as text embedding in the same embedding space. When these embeddings are, whenever these pathology are present in the image, the goal is to make them together in the embedding space, and when they're not present in the image, push them farther away. So these models, they have been shown to outperform the vision models in tasks like classification, which is great. But we looked in deeper into these text and image embeddings obtained from Conch and CLIP, and we found that they are not actually learning the pathology-aware semantics. How we did was we constructed two vocabulary sets, 500 common English words such as banana and chair, etc., and 500 pathology-specific terms. We were exclusively studying ovaries at that time, so we also had 20 words which were specifically related to ovary pathology. And we generated text embedding for all these 1,000 terms using CLIP and Conch. Then we computed pairwise similarity score between the text embedding and the image embedding and compared the distribution of those scores. So what we got was ovary-specific terms showed a slightly higher similarity scores in CLIP as expected, but overall the similarity range heavily overlapped in both the models. The green here in both the images are ovary-specific terms. The red is English words, and the blue is general pathology words. So you can see that there is major overlap between in the similarity range of these models. So this stems from the misalignment issue which has been shown in the CLIP models, both intermodality as well as intramodality. So this tells us that there is a big room for improvement in our methods to make and also test them in a more robust way to make sure that they are really capturing what we wish to. The key takeaways are we're training a mouse pathology model to analyze the massive volume of histology generated in labs, and then we also wish to improve these CLIP-derived text image embedding, which shows a significant misalignment. And that's my lab, and you can reach out to us if you're interested in our methods or learning more. Thank you.
Thank you, Ananya, for a nice presentation. The next team is XPath from Technical University of Munich.
There we go. Do you need notes?
I don't need to, do you need the notes, or do you need the notes for the presentation? Or? Okay, no, you don't need.
You're good. Okay. There we go. Easy transition.
All right. Hi, everyone. I'm Christian Grashey and my colleague Christian Rechmacher, and we are presenting our approach for the SLC-PFM competition XPath, multi-teacher knowledge distillation in pathology. So here we have another overview of the foundation models that have been released in the past years. And it's not also a full list, it's just a selection of the most popular ones and the public ones. And each model is represented by a circle, and that represents its size in terms of parameters. And as you can see, there's a trend not just to much more foundation models, like a growing number of foundation models, but also a trend of growing in size. And yeah, with recent foundation models having up to over 1 billion parameters, they're not very expensive to train, but also for inference, considering that you have to encode several thousand slide images for a single hosted image. So we want to promote smaller foundation models that are more accessible for also small institutions. And for that, as the title already promised, we are aiming to use knowledge distillation, which most of you have probably already heard of. It's the process of transferring knowledge from a larger model to a smaller model by hopefully keeping its quality, its representational quality and capabilities. And this also has already been used for pathology. An example is the recently released model HO Mini that is distilled from H Optimus 0 using standard DynaV2 distillation and TCGA data. And as you can see on the plot at the right side, this radar chart or radar plot, it almost, at least on those benchmarks, it almost achieves the performance of its much larger teacher model that is 12 times larger. So it's promising. But yeah, DynaV2 distillation has certain limitations. First, you basically can only do it on internally trained models because you need to wait for the iBot and the Dino head, which are commonly not public. And the second limitation is that it mimics the teacher model, so it kind of also copies the deficiencies of the teacher model. And we want to hopefully have a foundation model that's smaller, but also more robust. And for that, we're borrowing some inspiration from agglomerative models. These can have an arbitrary number of teachers. This is just like a showcase where we have 3 teachers and a much smaller student model. And we forward the image through the student model and the teacher models. And then for each teacher model, we have a protection head attached to the student model that protects the student embedding on the teacher embedding and then matches them with a similarity-based loss. And our architecture for XPath looks as follows. We are using 3 large teacher models, namely Uni2H, Workov2, and H Optimus 0, since they are very highly ranked and also like quite new ones. And our student model is also a vision transformer with base that is between 7 and 12 times smaller than the teacher models. And since all of them are vision transformers, we attach 2 MLP heads per teacher. One head that matches the CLS token, which holds a global representation, and one head that forwards all the patch tokens, which have the spatial features. And the training process looks as follows. We forward the images first through the student model and for all teacher models during the training. So we create like for each step all the embeddings. And then we match the outputs of the heads with the embedding of the respective teacher models, and also use we are aiming to use cosine similarity as the loss for that. And with that, I want to hand over to my colleague.
Thanks. Yeah, so we were not only thinking about how to increase efficiency using the model size, but also thinking about downstream tasks. And we did some experiments with existing foundation models, and we played a bit around with the embeddings. So we truncated the embedding sizes by selecting arbitrary indices, and we did, to ensure that we're not taking away the most important embeddings, we did 5-fold validation, so this is the standard deviation you're seeing here. And the interesting thing we noticed is that if we reduce the embedding size to about 1/8 of the original, so it's 87% reduction, the model performance stays quite stable. So we were thinking, can we compress these embeddings effectively? And for this, there's actually a nice approach called Matryoshka representation learning. It's an approach that basically uses these multi-layer perceptrons to compress down the embeddings. And it forces the embedding to structure itself hierarchically. so that you have the most important embeddings or embedding tokens at a specific part of the embedding itself. And then the further down you go, the less important it gets. And the nice thing about this is, the nice thing about this is it can be super easily integrated into our knowledge distillation approach because we already have these embeddings, right? And all we need to do is add some more for the different projections from the embedding. And then we are able to nicely truncate them. Next, we were also thinking about the data because it's super important for the model performance that we have clean or well-structured data. And MSK has, I think, already done a good job of cleaning out artifacts and stuff like that. But when we look at the chunks, this is just a random selection that I compiled on top here. There are very similar patches in there. And for our model to perform well, we want to diversify as much as possible in one batch. So we really want to increase batch entropy. And there's a solution called informed sampling that actually other foundation models like Rudolph 5 are using already. And here you basically want to take a very diverse set of patches to include into one batch. And you can group either on the slide level. So this is where you take, for example, metadata about the slide, which we unfortunately do not have. We know that maybe the chunks are just one different slide. So this is where we can go from there. But there's also the possibility of clustering the tissue altogether so that we might go from the picture down below to an information-rich batch as the picture on top. And we hope that the model converges faster through this and that it maybe also performs better. And as a nice bonus, if there are still artifacts left, they often get clustered into the same clusters. And by inspection of the different clusters, we can simply remove them. Yes, thanks.
Thank you so much. Next team is Ehus Aim from Akasus University Hospital.
It's, remember the name of it?
That's a good question. I just sent it to you.
This one, right? Oh, this is them. Maybe it didn't come through.
Oh, shit.
I don't see your name. Do you have your computer? Maybe you could just plug it in. You know what? Is this yours, guys? I forgot. I think I might have told them a different email. I found it.
That's the one.
I actually found it. I forgot. I told you my Gmail because it's a bigger file. There you go. I'll just have to scroll. Wow. Okay.
Yes, hello. My name is Agnar, and this is Sebastian. And we're PhD students at Akershus University Hospital. So the model that we created is called Odin. It takes its inspiration from the Norse god of knowledge and wisdom, and is also an acronym for Dino. So yes, this, I think it's mandatory to have a slide about the group that we are part of. So this is Artificial Intelligence Medical Informatics at Akershus University Hospital. It's a quite diverse group. Akershus University Hospital is the hospital in Norway that has the largest uptake area. So we, and also one of the largest in Scandinavia. So we collect a lot of patient data. Now, moving on to the method. We joined the competition in September. So our approach can mainly be boiled down to these 3 points. In September, we joined the competition, and that's when we look at the methods that dominated the field. They were mainly using Dino v2, like Uni, Open Midnight, Virtual. And in mid-August, Dino v3 were released. So we thought, okay, that's interesting. Let's try it out. So we trained a bit giant on Dino v3. And secondly, we have tried Muon with great success. And it's an optimizer that has twice the flop efficiency in LLM training over Adam. The update rule is pretty simple. We implemented it ourselves, firstly. And then now, recently, it is included in PyTorch 2.9. And thirdly, we curated the dataset that we were provided. So in automatic data curation for self-supervised learning, they post that datasets for self-supervised learning should be large, diverse, and balanced. The last point we can fix by the way in which we sample these datasets. So we use this approach, and we use the embeddings from Uni v2. Yes, so this is the computer that we had at hand. It has 3 GPUs, which came in handy for this large dataset. And these are the training hyperparameters that we used. We trained the bit giant model, which is 1.25 billion parameters for 250,000 iterations with a batch size of 32. And that gives, the model has then trained on 24 million images. Yes, and then I'll give it over to Sebastian here, who is going to present the initial results.
Okay, so let's look at the initial results. So we started basically by comparing the qualitative metrics of the model, and then we chose to use Uni 2 as a comparison, because that was kind of state of the art at the moment. So we took, for instance, here 3 images. We plotted the cosine similarity between the class token and patch tokens, and as you can see, it kind of focuses on the same cells as Uni, which we thought was a good result, but still has some other nuances. We also tried doing retrieval of images from the datasets using both Uni. As you can see here, it gets a lot of similar patches, and also with our own model, which is called Odin. And as you can see here, the similarity scores are quite high, but it still chooses some different patches from Uni. We also tried to kind of see how the model learned during training. So we plotted the class cosine similarity of the class token and the patch token during training iterations. And as you can see here, the first column is the image. And then you have the first iteration, which is just random weights. And then you have each 50,000 iterations. And what's interesting here is kind of what it learns during training. And first, it has a high cosine similarity on non-cellular tissues. But as it progresses, it focuses more and more on the cells. We can also kind of look at the evolution of patch similarity, which is you can choose a single patch and then calculate the cosine similarity between all the other patches. And here we have a small red box which we've chosen, which is a kind of a cell in the tissue, and then as it progresses, the similarity between the cells in the image is higher, which is we also thought was a good sign. We also tried to calculate the stability, which is a measure of how often an image keeps the same 10 nearest neighbors after an augmentation. We used 3 different augmentations, and the higher the stability, then you have a more stable and reliable embedding space. Our model did better than Uni in this metric by 12%. We thought this might be due to the new positional encoding from DynaV3, which uses a custom rope and not learnable positional encoding. Even if this is not a measure of the actual performance, but we still thought it was a good sign. We didn't have any labels from the data set we were given, but we tried to do a benchmark on 2 public data sets initially by doing linear probing. And then we chose the Brax and CRC. And for this, Uni performed better on both data sets, which is kind of unfortunate for us, but still our model has seen around 10 times less data, which might explain some of the performance gaps. So we hope maybe when we get more data, we can get a better performance as well. That's it. Thank you for your attention.
The next team is the MedSec from University of Toronto.
USB-C. Yeah. Oh, do you actually have yours? Yeah, I think I have yours. Yeah. It's. Do you remember the name of your talk?
I think it is a Google slide.
The Google slide.
Yeah, it's a Google slide.
I think I downloaded it though. Let's see.
This one, Pathology Native Self-Supervised Information.
Oh yes, perfect.
Okay. Hello everyone. We're the Fight Tumor team at the University of Toronto. My name is Sholan Yin, and along with Streamman Bowan, we're excited to present our work, Pathology Native Self-Supervision at Scale, specifically adapting DynaV3 for cancer foundation models. We started with a clear problem that general vision models are powerful, but they don't speak pathology. As we all know, DynaV3 is currently one of the state-of-the-art for the natural images, but when you apply it directly to the pathology task, you'll find there's 10 to 20% performance degradations. And this is a reason that's specifically because there are some fundamental mismatches between the natural images and pathologies. For example, first one, the color, it is distributed in H&E staining, which is different from the natural images. And secondly, the magnification. The pathology is examining tissue at multiple scales, like 20 to like 20 or 40s, which the natural images doesn't. Certainly, the orientations. The tissue orients is biologically arbitrary, but the natural images doesn't. To bridge this gap, we have introduced 3 pathology-specific adaptations. Firstly, biological stain augmentation. Secondly, rotation invariance. And third, multi-resolution attention. First, we start with first innovation. Standard color jittering isn't enough. We have implemented the HED jittering. And technically, we have converted the RGB space into optical density space, and we independently increase the H&E channel to plus or minus 5%. And this matters because it simulates a realistic interlaboratory stain variation that's caused by different chemicals or scanners. Forcing the model to learn morphology rather than just memorizing the color palettes. Second, we tackled orientation. In pathology, there is no up or down, so we apply a random 90-degree rotation and vertical flips with a probability of 1, which means every image is transformed. This effectively quadruples our training data and prevents the model from learning orientation bias. So the model learns that the tumor is a tumor regardless how the slide was placed under the scanner. Third, we have tuned the DynaV3's original multi-resolution attention into a pathology-specific approach. We mirror the pathologist's workflow by firstly looks at the whole tissue architecture and then zooms in for nuclear details. And we start from the standard DynaV3 multi-crop scheme. As you can see, they have the global crops scale for 0.32 to 1 and the local crop scale from 0.05 to 0.32, which there are no difference from the minimum of the global crops and the maximum of the local crops, which doesn't really differentiate between the high level and low level details. So from this, we then design a pathology-tuned multi-crop setup with a larger global crops and a stricter scale ranges to emphasize the tissue architecture context, and also a smaller but more numerous local crops to emphasize the nuclear morphology. This encouraged the model to learn scale invariance and integrating both architectural and cytological features. Here is an engine-driven our model. We have utilized the student-teacher network, which is adapted from DynaV3 that combines 3 specific loss functions. Firstly, the dyno loss for knowledge distillation. Second, the eyeball loss for mask modeling, where the student predicts the features from the masked patches. And third, the cardio loss to maximize the feature diversity and prevents collapse. And the teacher is updated via the exponential moving average, as known as EMA, to provide a stable target for the students. And to validate our approach, we have built a rigorous 2-stage pipeline. In stage 1, we have used Trident from the Mohammed lab for WSI pre-processing, handling segmentation, patching, and also the feature extraction. After the features being representation being extracted, we will feed them into the downstream evaluation pipeline from the MSTAR framework and using the ABML model. Our specific focus was a BAP1 mutation prediction task. For our experiment, we have used a CPTAC CCRCC dataset and the labels from the pathobench. Crucially, we have employed a frozen encoder protocol, which we kept our pre-trained VAT small model weights fixed and only trained attention head and classifier from the ABML. And this ensured that the result reflect the quality of the features only that our model learns during the self-supervision, but not just like the capacity of the classifiers. And now the results. We trained our VAT small model on 11 terabytes of non-DTA data. And despite being the smallest model, which we have compared with Conj V1.5 and Uni V2, which I believe these were based on the VAT large and VAT huge backbone. And our approach, which you can see on the orange bar, has achieved the AUC of 0.81 and weighted accuracy of 0.82, which has outperformed all of other models, including the DynaV3 baseline. This validates that our pathology native adoption significantly improved the feature qualities. In summary, we have achieved two main goals. Firstly, the domain adoption. We have successfully adopted DynaV3 using stain augmentation, rotation invariance, and multi-resolution attention. And secondly, we have the evaluation readiness. We have a proven pipeline using the frozen feature extraction that delivers high performance on patient-level tasks like BAP1 predictions. Looking ahead, we plan to scale the model to moving from VAT small to VAT large for even richer representations, and scale the data to extend the training to include the full DTA data, and thirdly, evaluation at scales to explore more downstream evaluation tasks for more comprehensive result, and lastly, interpretability. We plan to visualizing the attention patterns for clinical validations. And that's it. I think this concludes my presentation. Thank you for your time, and yeah.
Thank you for the presentation. We have limited space on the stage for the chairs. Yeah. Yeah, one person per team. Yeah, that would be great. Thank you. The next presentation is from team Tar Heel Path Founders from University of North Carolina at Chapel Hill.
Hi everyone, my name is Xinjie Qian and I'm a PhD student at UNC. And I'm here to present our work on pathology-aware visual embeddings via vision language alignment. And our team name is Tar Heel Path Founders, and I'm excited to share a new framework we have developed, one that trains a foundation model directly from the unlabeled histopathology image tiles, removing heavy dependency on metadata. And yeah, let's start with the core problem. So the primary challenge in computational pathology is data efficiency. We typically rely on expensive labels, but our goal is to train foundational models directly from unlabeled tiles. While standard self-supervised models are great at capturing visual semantics, they suffer from a critical blind spot. They lack pathology-specific context. And essentially, there's a gap between the general visual features and specialized medical knowledge. The current models struggle to bridge this, which limits their performance on downstream tasks. To solve this, we introduce a vision language alignment framework. Our hypothesis is simple but powerful. We can take these context-blind visual embeddings and enhance them by injecting domain-specific linguistic supervision. By aligning visual data with medical language data, we create what we call pathology-aware embeddings. This approach allows us to leverage the robust feature extraction of vision models and deep semantic understanding of medical language models. Let's dive into how this pipeline works. Starting with the visual branch, our process begins by extracting high-resolution image tiles from whole slide images. And to process these images, we utilize DynaV3, which is current Soto, self-supervised vision transformers. DynaV3 is incredibly effective at capturing visual structure, and it generates our initial tile embeddings. However, as I mentioned before, while these embeddings are visually descriptive, they don't know pathology. So they see shapes and textures, but they don't understand the tumor or stroma in a medical sense. This is where our second branch comes in. So this is the language branch designed to inject that missing pathological knowledge. We employ cutting-edge vision language model, such as queuing or lava. We prompt them using general instruction to describe the tile's morphological and pathological features in detail. And this effectively transforms the abstract visual content into the semantically meaningful text. And once we have these descriptions, we encode them using Gautron. For those unfamiliar with the Gautron is a biomedical language model pre-trained specifically on clinical and pathological data. And by using the Gautron, we ensure that our textual embeddings are dense and deeply grounded in medical semantics. And now we have a vision embedding and a medical text embedding. And how do we merge them? The crucial step is alignment. So we integrate these embeddings using a clip-style dual encoder architecture. We jointly optimize the Dino V3 imaging encoder and the Gautron text encoder using a contrastive loss. And this loss function encourages the model to pull the embeddings of matched imaging text pairs closer together and pushing matched pairs apart. And this contrastive learning paradigms allows the vision encoder to be modulated by language-based pathology priors, and the vision model starts to learn to recognize these medical meaningful patterns. And the result of this process is a highly effective pathology-aware image embedding. And unlike standard embeddings, these are sensitive to histological structures and disease-relevant features. These embeddings are ready to be deployed directly into downstream tasks like classification, clustering, and survival prediction. So, and critically, our method offers three major advantages. It is model agnostic, it is scalable, and it requires no manual annotations. And since we do not have entire data, we currently train our model on 3 million tiles, and our results outperforms most of the current baseline methods. Yeah, that's all for my presentation. Thank you.
Thank you everyone for wonderful presentations and for doing really the hard work of pushing the innovations on developing new foundation models. We have 4 more presentations that are virtual. We'll play at the end of the workshop. Right now the floor is open for questions. We'll have 5 minutes of questions, but participants are here. You can interact with them later on. If you have any questions, please feel free to use the microphone to ask those. Is this one working?
Thank you, everybody. Really great talks, really impressive work so far. It'll be even more exciting when the full data set is available to everybody. You'll be able to extend your methods. Sorry, I didn't get your first name, but from the University of Toronto, working with Dino V3, it seemed like you got really good results. We kind of had more mixed results and in trying to implement some of the Dino V3 methods, in particular, but it is also very challenging because of how large the model is and the compute requirements off of their GitHub page. How are you able to work with more standard size hardware and get the implementation of Dino v3 to work. Thank you.
Oh, yeah. So for this question, I think we have, are you specifically like asking our technical details of the training hardware or the?
Yeah, because if you use just the GitHub, they require dozens of GPUs off the shelf, and I'm guessing you probably were using a smaller hardware set. Did you have to? What modifications did you have to make to the code to make that work?
Yeah, so we have utilized like 4 H100 GPU and I think FP16 for the precision. Yeah, and that is the resource that we have utilized.
Great. Okay.
Hi, my name is Christoph Garas. I am from Attraxis AI. I have a question to actually whoever is willing to answer. So can you comment on how you have done hyperparameter selection in your models? So, okay, so what I mean is, actually if you look into Dino v2 paper, Dino v3, whatever you choose, there's maybe 30 hyperparameters that you can actually, or maybe perhaps more than that. So I'm just wondering if you had any kind of systematic way of selecting them beyond just using whatever somebody else has used.
I think you want to answer that question.
Yeah, so we actually went for the Dino v2 approach. So we actually just reused those parameters and tried to have them more similar to the ones that are reported in the paper.
Next question, we can go to the next one.
Hi, my name is Shivam. I am an AI and neuropathology researcher. And I have observed that usually, even on fine-tuning CLIP or conch-like models, they usually have some sort of misalignment issues. So I wanted to ask the latest presentation on where you used like the Dino v3 vision encoder and a Gatortron text encoder. Did you do any vision language alignment analysis? And like what was like the quality of these features and how were they aligned with what you would expect them to see?
So for the vision embedding, we use the Dino v3, and for the texture embedding, we use the Gatortron, and so since they are on different modality data and their embeddings are very different, and so our goal is to try to find some common information from these two type of data, from these two type of embeddings, and so they may be not perfect to align with, but they will be aligning in a common space with the large similarities, and it does have some problems in the perfect alignment, but I think so since the base model has a large the base model are trained from a large data set, so they probably have some potential patterns which can recognize from these two, the language and the vision embeddings. So I think, and since we have a little test through a small data set, and we found that the results is very good.
Yeah, no, I understand that training it with a text encoder will add some extra domain knowledge into the visual embeddings. I'm asking, were you able to see that something related to a pathology text was actually able to represent like a pathology feature that corresponds in the image? For example, if you see if you see the word tumor, did it actually represent the area of the tumor inside the image based on these embeddings?
I think we are really pressed for time here. You can take the questions of
thank you so much for the
one last question we'll take.
Hi, this is a question for the mouse model. I noticed that you chose to fine-tune Dino v3. I'm just curious why the transfer learning was better. I would have tried to. I'm just curious if you tried to compare it with a pathology foundation model as a starting point rather than Dino v3, and if there's any difference. So, yeah.
Yeah, so we are fine-tuning Uni 2 with the mouse pathology data, and we do not have the results yet.
Okay.
We do wish to compare both.
Thank you so much for the questions, and thank you for the presentation. You can take the seats, but they will be here if you want to interact further. After the workshop, you can ask more questions. Now we'll move on to organizer presentations. The first one is Dr. Ruchika Verma from Icahn School of Medicine at Mount Sinai.
Have it just under your name. There you are. You can just slideshow here. Oh, it's not showing up there.
It takes like 3 seconds. There you go.
Sounds good. I'm glad to be here and share some of my recent work on Neuropathology Foundation model. First, I'll talk about the evolution of medical imaging using AI. Over the past few years, there has been a paradigm shift in medical imaging using AI. For example, people have been working on task-specific models where each task requires its own model, and the model was trained using tens or thousands of images, specifically labeled examples, and it was trained from scratch. So it requires expensive annotations, and it could also lead to isolated models because every task requires its own model, so which was an inefficient process. Then foundation models came where we can train a single foundation model using millions of images or data points. And then one foundation model could be used for several downstream tasks. For example, here I'm listing task A, B, and C. So this requires transfer learning, and less label data is required for using foundation models for several downstream tasks. But these general purpose foundation models may not be able to capture specific morphological patterns that are important for neuropathology. So that's where domain-specific foundation models come, and currently we are working on neuropathology-specific foundation model. And we hypothesize that this would be able to diagnose rare diseases, and it could have better performance for neuropathology-specific downstream tasks. I think most of the people have already covered these pathology foundation models. So there is Uni, there is Conch. These have been already used for several downstream applications. And there is Gigapath. I think I've seen slides of this as well. So this was trained over a bigger architecture and more data. But the bigger architecture doesn't mean the model is going to be better. So there is a limitation in the general purpose pathology foundation models. They don't have specific training on neuropathology data, and they are not able to diagnose rare diseases. So that could limit their ability to recognize complex visual patterns that are important for neurological conditions. So here I'm giving a brief overview of the diversity and complexity of neuropathological conditions. For example, here we can see there is toxic, traumatic, infectious, inflammatory, neoplastic, degenerative, psychiatric, genetic, metabolic, and developmental neuropathological conditions. So if we are going to look at the whole slide images or tissue sample of these specific neuropathological conditions, they will look like these. And in these images, we can see that there are different morphological patterns which are important to diagnose these neuropathological conditions. So it requires specialized visual pattern recognition, understanding of rare presentations, and domain-specific knowledge. That's where a neuropathology-specific foundation model could help. So we have developed a neuropathology foundation model using data from US as well as England. So these I'm listing some of the sites from where we source the data for training our model as well as testing our model on several downstream tasks. So in total, we used 585,000 slides and 1 billion tiles we extracted out of those to train our model. The model was trained on H&E whole slide images using 20x resolution. And it was trained using DynoV2 architecture, using 24 H100 GPUs. So out of those 1 billion tiles, we used 800 million tiles specifically from brain, and 200 million tiles are used from other general pathology data to avoid overfitting of brain-specific artifacts. And we compared our model with several state-of-the-art pathology foundation models that include Uni2, GigaPath, Virchow, and Virchow2. Here we can see they are trained with organs ranging from 17 to 200, but we focus specifically on neuropathology specific training, and we focused on data from central nervous system specific instead of doing multi-organ generalization, because we hypothesized that this would be able to do accurate brain disease diagnosis. This work is currently, like, we are working on the manuscript and the work is unpublished, but we do have released the model on Hugging Face. If anybody would like to test it out on their downstream tasks, feel free to do so. The link is available at the bottom. After training the model, we tested our model on several downstream tasks. For example, here, once we have the whole slide image, we can extract tiles, then we can extract multiple tiles from one whole slide image, so we'll have a bag of tiles, and then we pass it through the Neuropathology Foundation model, extract features, and then we have a aggregator, which is ABMIL, and then classifier is used on top for the classification. So in total, we tested our model on 59 downstream tasks, but we categorized those tasks into 11 disease categories, because we wanted to concise that information to see like how it is going to perform on several neurodegenerative diseases. So I can talk about some of the disease categories. For example, one was neurodegeneration ataxia, where we are looking at the essential tremor, which is a movement disorder characterized by involuntary rhythmic shaking of the certain body parts, and then spinocerebellar ataxia, which is a rare genetic disorder that causes progressive loss of balance, coordination, and muscle control. So here I'm showing a heat map where in the y-axis I'm showing different tasks. In the x-axis I'm showing the encoder values, and here I'm showing the AUC values on the held out cohort. This is the color bar that shows green color means like more AUC, and the blue color represent lower AUC, and the bold color shows which one is giving us the best AUC for the specific task. And the encoders are sorted in terms of decreasing order of AUC. So the bottom left encoder means the model performed well for all the tasks I'm listing for one disease category here. So here we saw that the NeurIPS did better for both of these tasks. And overall also the AUC was 0.934 in comparison to other general purpose pathology foundation models. And then we also tested it on several other downstream tasks. This is the data which we got from NIH Brain and Tissue Repository. Here we had 6 different tasks where we looked at normal brain, Alzheimer, vascular disease, Lewy bodies, Lewy body dementia with Alzheimer, and we did a 6-class classification. And also we tried to have like one versus all classification. For example, here we tried to look at like Alzheimer tissue slides versus others, and we tried to see like how the model is gonna compare in comparison to other general purpose pathology foundation models. So in all these tasks also we saw that the NeurIPS outperformed over other general purpose foundation models. And when we looked at the mean AUC for all these tasks that comes under neurodegeneration mixed dementia, there also we saw that NeurIPS did better in comparison to other pathology foundation models. Similarly, we tried to look at the brain tumors, including IDH mutation, MGMT molecular status, grade prediction, and histomolecular subtype prediction. We also used eBrains data, which is publicly available, and do 12-class coarse and 30-class fine subtypes classification. And we also used Mount Sinai data for meningioma grade and meningioma recurrence prediction. So here we saw that the GigaPath did better in comparison to others, but the difference is not like very significant or large. You can see like NeurIPS is 0.903 mean AUC, and the GigaPath is 0.905. The main reason behind this is like these general purpose pathology foundation models are trained specifically on the cancer specific data sets. Since these tasks are mainly from the tumor categorization, so it was obvious that they were going to do comparably well in comparison to NeuroFM. But for the MGMT status, we can see that this is a challenging task because none of the model performed better than 0.7 AUC. So, but the NeuroFM did good here and was able to identify molecular status from their TCG data. And then we also tried to have this hippocampus subfield segmentation. So this region represents the hippocampus area. And these are the 5 anatomical regions which we're trying to do, we were trying to extract tiles from this, and model was learning to segregate these tiles into these 5 regions. That includes CA1, CA2, CA3, dentate iris, and subiculum. And we saw that the NeuroFM model was able to segregate these tiles better than other foundation models. So anatomically also it was able to identify these regions. So here I'm listing overall results. I'm showing the box plot of all the classification benchmarking tasks we had, and here we saw that the NeuroFM was doing better in comparison to other pathology foundation models. And we also tried to show different disease categories, like 11 disease categories that we were using to categorize our 59 tasks to see like where we are doing better or where we are lacking. So for some of the tasks, we saw that some other pathology foundation models did better, for example, neuroinfection, HIV, or FTLD pathology, but they had some signatures which are common in other body parts. So that was also like expected. They were not like neuropathology specific signatures that are important to identify these tasks. And then we also tried to compare AUC value with the model parameters. And we saw that even our model had like lesser parameters. It did well in terms of AUC. And there is no correlation of having like bigger model or bigger architecture means it's going to be better. So it shows poor correlation there as well. So it is more important like what information we are giving into the model. We also did head-to-head comparison for each of the tasks to compare with the best performing model for the same task to see like whether there is a significant separation, like if our model is doing significantly better than the other or not. So here we saw that like NeuroFM did significantly better for 12 tasks. 23 shows like how many ties. Ties means like there is no significant separation between our model performance versus the other, and the 25 means like where it did poorer. So overall, like for in terms of better performance, NeuroFM did well. It shows 12 tasks in comparison to Workow, 2 Workow, and Gigapath, and so on. Uni didn't show any task that did significantly better than other best performing encoder. And then we try to understand like what are the tasks which are showing significantly better separation and where our model is going to give the value. So here we saw that they were mainly from Alzheimer's disease, mixed dementia, Alzheimer's diagnosis, Lewy body dementia, vascular dementia, ataxia tasks that include essential tremors, spinocerebellar ataxia, and hippocampal subfields classification. So we identified that specialized training effectively capture important morphological patterns for challenging differential diagnosis in neuropathology. And then apart from that, we also did region and stain specific analysis because we had one cohort where we had around 6,000 slides that were coming from different brain regions, which I'm listing here. For example, cortex, hippocampus. So we knew like these slides are coming from these brain regions. And then we also know that they were coming from different stains. So these are the 6 stains we used that include LHE, 88, Beal, silver stain, amyloid beta, etc. And we did analysis again and compared other foundation models to see if region and stain specific analysis categories are going to do better if we are comparing NeuroFM with other. And there also we saw like NeuroFM did well and comparable with the other one, which is Uni2, and the other models didn't do well for all these tasks. So here I'm showing some results from atrophy related tasks. Again, here NeuroFM did better in terms of mean AUC for all these tasks, which include cerebral cortex atrophy from LHE stain, lobar atrophy, hippocampus atrophy, etc. And we also tried to dichotomize all the tasks we had under Alzheimer's disease and see like if there are specific stains which are going to give us better results or like which are more predictive for specific things. For example, for thal phase or CIRAD score, we found that amyloid beta was giving us better results across all encoders. So that was similar to what pathologists see, because they also look at the amyloid beta stain for these kind of diagnoses. So that also shows like these pathology models are actually looking at the informative regions to have these kind of diagnosis. So LHE stain was not that predictive for these Lewy body specific things or like structures to identify. And similarly for Braak stage, we saw that 88 stain was better. And overall, again, NeurIPS did better in terms of mean AUC. But when we try to segregate this information and see like these pathology models are actually looking at the correct stain for these kind of diagnoses, that also we saw that it gave higher performance for those important stains. Then we also did this disease categorization and see like how NeurIPS is doing for separate disease categories, and it was overall doing better, except one, which is cerebrovascular pathology. The cerebral vascular things are always like available in all other organs also. So general purpose foundation models also did well for vascular related tasks. And again, we did head-to-head comparison, and NeurIPS did better for 9 different tasks. Statistically in comparison to other foundation models. So it does have a value for neurodegenerative diseases. And I tried to show like what are the tasks where NeurIPS was doing better, which was mainly Braak score, CIRAD score, etc. And then we also did ablation study where we tried to have like other neuropathology variants. For example, the model which I was talking about was trained on H&E stains only, but we also had a separate model which was trained on IHC stained images. One model was trained on multi-stain, and we tried to compare all the models with on IHC stains tasks to see like if H&E model can pick up information from the IHC stain as well. And there also we saw that the NeurIPS overall did better, so it does capture information from the IHC stain as well. I think I'm already over time, so I might not talk about the other ablation studies, but yeah, so overall we saw that it does have a value for the neurodegenerative diseases, and it did well for the IHC stain specific tasks, so it would be useful even in those conditions where the IHC stain is not available, so it can pick up signatures from the H&E stains. At the end, I would like to thank all my lab members as well as collaborators. I can take questions at the end. I'm sitting there. If anybody has any questions, please feel free to reach out.
Thank you, Ruchika. The next presentation is from Dr. Hamid Tizhoosh from Mayo Clinic.
I chose the right one. I'll turn off that. There you go. All right, thank you.
Good afternoon, everybody. So this is the team that will evaluate search and retrieval for submitted models. Saghir Al-Fasli is here, Wataru Ogami is our pathologist, and I will be involved as well. So we will have whole site images. As you know, we have to select some patches in contrast to classification. You cannot just do bags and things like that. You have to select a deterministic number of patches because you have to index them, very different from classification. And then deep networks come in, you get your embedding, which you can understand as index, and then you have an atlas, and then you search in an atlas and do whatever is necessary to do subtyping or so. So if you take the gigapixel image, again, you know everybody does patching, but the main difference is that you need a selected number of patches that we do in an unsupervised way because it has to be applicable to everything. It cannot be trained. Then the embedding comes. Then we combine them in some way. It could be aggregation, median of minimums. It could be some sort of hashing to make them more practical. So historically, the community has worked on subsetting. We gave that up some years ago. I don't know, 15 years ago. Nobody is working on subsetting anymore because that's a detection. So it needs training So nobody does subsetting. Instead, we do patching, which again, so we are used to just get some random patches. Well, what that doesn't work for search and retrieval. So it has to be a fixed, less stochastic set of patches. So, and this is important because I saw some of you look at search and retrieval for patches. Don't do that because we will not test like that. So we will compare whole slide image with whole slide image, no aggregation involved. That's the way we do it. You get some patches from the query whole slide image. You have some patches from the image that you are comparing to. You compare all embeddings of the input image with the all embeddings of the image to be compared. For each embedding, you take the minimum distance, and then across all embeddings, you get the median of minimums. You have a measure. So I had discussions with colleagues, and they were complaining, well, that's not fair because aggregation is better. No. So our experience shows that aggregation actually can make things worse. So I will show you some examples for that. So aggregation is saying this. So, and again, we are doing whole slide image search and retrieval to evaluate your models. We will not do aggregation because, first of all, aggregation as a technology is in its infancy. It's not a settled business. Nobody knows how to do it. So we will not touch it. So we will do the median of minimum as I showed you. So in this paper, just if you want to get some comfort, in this paper we compared GigaPath using median of minimum approach and GigaPath with their own aggregation technique. And as you can see, aggregation in most cases actually made the results worse. So it didn't bring any improvement. So don't worry about that. The median of minimum all patches compared to all patches will do that. If you want to try and test your own approach, go to our GitHub. You can have the code. You can exactly know how the result would be for your own approach. No patch comparison, WSI comparison, and then you can search. You can find the top 1, top 3, top 5. So the way that we calculate the accuracy, everybody knows that. I'm just going for the sake of completeness. So you get that the top 5, some of them are correct, some of them they are not. And then you get either top N accuracy or majority N. So computer vision community is used to, when you say top N search results, you say if one of them is correct, it's correct, because that comes from the days that you were searching for a dog, and then you get a set of images on the first page of Google, and if one of them was dog, you were happy, so that's correct. No, in medicine, we need the absolute majority of retrieval cases to be correct. So not top 1 in sense of computer vision, but majority of top 1 has to be correct. So if you have top 5, at least 3 of them have to have the correct label to be regarded correct. So of course, we calculate F1 score. Of course, ROC doesn't mean anything, and F1 score is the practical thing. And whenever you have imbalanced data, which is always in medicine, F1 is very, very difficult to get high values. So we will test your models for WSI retrieval for 2 cases, skin and breast, very difficult data sets. We are giving you some idea. So the skin data sets, we have 35,000 whole slide images, more than 100 classes, categories, subtypes, very, very difficult data set. So we selected the top 20 classes, which at least have 40 cases. So we made it a little bit easy. And so we randomly selected, so 1 whole slide image per case because every patient has multiple whole slide images. So these are the top, the 20 classes for the skin. So is a 20 class classification. For breast will be 22 classes roughly. So very difficult data set, again, highly imbalanced. I cannot even say imbalance. If you have 5,000 here and 5 here, this is not imbalance. We have to invent another name for it, but this is the reality of clinical data. So, and then just to give you some ideas about some of the mostly used and mostly cited foundation models that we tested, this is the reality of foundation model for search and retrieval. So you are below 50%. And the paper that I showed you in scientific report, the average of all foundation models for TCGA is 44%. And magically, all of them land around the same number. This is very strange. Why they all provide, when you do it for 25 organs and 117 subtypes, all of them, the average comes around 44%. And you see here that, again, is very difficult to get anything above, even close to 50%. So I would say the competition will be successful, and I'm expecting that this will be worse for breast. Breast will be more difficult than this. And if you cross 50%, that's a huge success. 60% would be amazing, 50% would be amazing, but if we want to talk about breakthrough, we have to get these numbers to 70%. 70% F1 score for top 1, top 3, top 5 in search and retrieval. That's, again, when I talked about my comment about the zero-shot requirement of foundation models, this is it. So otherwise, why should I use a foundation model? So what would VGG give me if I take VGG and just fine-tune it with 500 whole slide images? So just give you an image. If you want to know more detail how you can test your model for search and retrieval, talk to us. That's it. Thank you so much.
Next, we have Kostas Triaridis from Stony Brook.
All right. Hey, everybody. So everyone before me was talking about all those big self-supervised foundation models for pathology and how you can use them and the embeddings they produce to do clinically useful stuff like diagnosis, prognosis, or retrieval. So I want to take you to a different place. What is another way that we can actually use those representations in a useful manner? So in our group, what we have been doing the past few years is we have been using those representations to actually do pathology image generation. And why would anyone want to generate pathology images? Well, imagine a case where a pathologist wants to talk about a specific case or how a specific cancer or how a specific subtype would progress and how it would look in an image in an educational setting. So instead of having to retrieve a specific sample that would have any information that he wants to talk about, maybe he wants to generate an image that is going to have all the information that he wants to share. Another idea is that with medical data, when you're working with patients, it's very hard to be able to share those data to train all the big models that you want to train. So if you're able to generate synthetic data that is very similar in the distributions to the real data, then maybe this data can be useful for training all those big models that we want to use. And this is especially true when people have been doing data augmentation, because for the downstream tasks, the data sets are usually really small. So you need to do data augmentation to make this work. So specifically, when you want to generate pathology images, what are the big challenges? One of the biggest challenges is that all the other generative models, like people have been using Stable Diffusion, or they have been asking ChatGPT to generate images, is that they are using text. But with pathology, it's very difficult to train a text-to-image model because all of the text data that you have, all the descriptions, all the reports are usually at whole slide level. And we want to train patch level models because training a model that can generate 30K by 30K or even bigger images in pixels is infeasible. So we want to train it at a tile level first, but the descriptions that we have are on the slide level. So everything is patched. So what did we do to counteract this is our first work on this, on CVPR24, where instead of using text, which has been the standard way for generative models, we used learned representations, so SSL representations. So what we did is we took a self-supervised model. You can use Uni, you can use Verkov. I think this is older, so we used HIPT, which was the best one at the time. And we took an image, we passed it through the SSL encoder to get the SSL embeddings, And we use those embeddings to condition the generative model, to create variations of this image. And we found out that the synthesized patches that we were making were closely following the semantics of the image that we were giving. So we could actually generate images that were very good at doing what we wanted it to do. And when we used this model to perform data augmentations for downstream tasks, we actually found that, especially when we were constrained in data, in the small data sets, we actually could really improve the performance of the downstream models. And another thing that we tried doing is, okay, so if we can train this on a larger scale, since we can obtain those self-supervised representations, then can we adopt it to be able to do text, since maybe that's the thing we want to do in the end. And you can actually do this by just training just a very small auxiliary model that will generate those SSL embeddings based on the text, which is a much easier task. But still, we also want to be able to generate large images. And those large images need to have some kind of global structure that you would find on those real WSIs. And in the way we had been doing it thus far, the model actually produces its style separately. So it fails to capture some kind of global context. And we addressed this in our follow-up work in this year's CVPR, where our answer to this, to how to counteract this for large images like 4K or 8K or even whole slide level images, was that we had to train a multi-scale model. So our idea was that in order to be able to make those large images, what you need is a model that can understand those pathology images at multiple scales. So at the biggest magnifications like 20x, but also very zoomed out, like 0.1x. So our adaptation was that we trained the same idea of a model, and we extracted the patches, we generate the SSL embeddings for different regions in the image of different sizes. And we push through all of those SSL embeddings through a single network that summarized them in a shared latent space for all magnification, and we train the model for all magnification. So this model can produce 256 by 256 tiles, but at multiple magnifications. And by doing this, we were able to reach state-of-the-art in all of the magnification, because our model was able to understand the images at different scales. And by being able to generate images that understand like pathology context in different scales, we could also propose an algorithm that would generate images that were very large by generating tiles, but at the same time constrain the tile generation so that they follow a global context. So essentially, we generate images at zoomed out and zoomed in scales at the same time, so that the zoomed in images who are generated independently follow the global context of the zoomed out image. And this allowed us to make very large images that could follow global context and had semantics that closely followed the real pathology images. And you could see that, for example, here, we're able to have those global structure maintained. And so our next work for this, since we're talking about foundation models, was what's next? So we need to scale this up. We have those good generative models that can follow semantics closely, but this is still, we had only done this for breast cancer tissue, and we hadn't applied it to all cancer types. This was a smaller model. So our next idea was to propose a model that could do it on a foundation level scale. And this model, for this training, we collected a big data set of 70,000 whole slide images to train on from multiple cancer types. This was around 500 million tiles in total. And we trained the model using the techniques that we used previously. And we used Uni as the self-supervised conditioner. And the images that we can make generate synthetic data that very closely follows the semantics of what was there. And we have a model that can generate images at 256 by 256 pixels or 1024 by 1024 pixels. So we scaled up the model size as well. And this resulted in images that looked very good and were much better for generative data augmentations for our downstream tasks. But okay, we had already done generative data augmentation. What is more useful than this? So we found out that one thing that we were pushing with our generative models is that organizations can actually share the synthetic data more easily than they can share the real data, since the real data correspond to real patients. So there's a big block there in order to share it with other organizations. So we benchmarked our model to say, okay, if I want to share a version of my data set, is it useful for me to create a synthetic version and share that? Will the institution that is going to train the SSL foundational models be able to use the synthetic images and actually improve their training? And we tested that by training SSL models on TCGA real images and generating a synthetic version of the HistAI dataset. And we found out that the models that were using both real and synthetic data could actually improve over the models that could only use the real data. So we think that generating synthetic data for augmentations like this is useful. And to make our model more useful as well, what we did next was we created a small control net so that you can condition it on cell mask as well. So you can have more fine-grained control in the images that you generate. So you can choose a style image, so the tissue that you want to generate, what kind of cancer it is, and you can create cell masks and have the model generate images that follow the cell mask but will correspond to the semantics that you want as well. And one thing that we were able to do, since, okay, we're talking about foundation models, and people, when they talk about foundation models, usually mention tasks that the model is able to do zero-shot. And in our case, we consider our model a foundation model because it can generalize to unseen stains. So what we found out is that if we pass, even though our model is only trained on H&E images, if we pass some IHC images through the self-supervised models like Uni and give it to our model, then our model can generate something useful. So here we have some images from Pixel that are generated using embeddings of IHC images. And when we found that out, we thought that this is a very good way to do virtual staining in a way that follows the semantics that we want. So we are able, this way we're able to do virtual staining by just translating embeddings from AHC images to Uni embeddings from H&E images to Uni embeddings from IHC images. And then we just generate the corresponding image with Pixel. And we can do this with zero-shot, but we actually, in order to increase the performance for some artifacts that were being generated, we fine-tuned the model just a little bit to achieve better results. And for this task, we also found that, if Dr. Kanan told you that AUC is not as reliable as a metric, you know that the generative metrics are even worse. So we actually gave these images to pathologists and told them to score them. And we found out that when you move the data scale to a foundational model like Pixel, the virtual staining that you're able to do is actually much, much better from the eyes of a pathologist, and it more closely follows what you want to generate when you're doing virtual staining. So we have published our models on Hugging Face, and we have our project page on GitHub for anyone to use, and we have our training code as well, and you can find all of those online. Thank you.
Thank you everyone for joining in today. We have one more presentation and 4 virtual talks, but we will communicate with the participants through email. We are just really out of time at the moment, but we can gather outside and take questions and talk about issues that you might be facing for continuing.
Hello everyone, this is Rukhmini Bandyopadhyay from MD Anderson Cancer Center. Today I'm going to talk about foundation models in computational pathology, especially in the lung immunotherapy data. So the first slide is about who are going to benefit it from immune checkpoint inhibitors. So here we show a whole slide image, like something every patient already provides as part of standard clinical care. This slide captures tremendous amount of information about the tumor and its surrounding microenvironment, but much of this complexity is difficult to quantify manually. AI allows us to extract these subtle morphological and spatial patterns at scale. So our goal is to use these patterns to predict clinical endpoints like OS, that is overall survival, and PFS, that is progression-free survival. Together, these outcomes from the benchmarks for assessing benefit from immune checkpoint inhibitors. So here below we highlight there are different biomarkers that helps to, these are the landscape of biomarkers for immunotherapy, PD-L1 expression, TMB, mismatch, repair deficiency, which captures a piece of biology, but none are sufficiently reliable on their own, as many require specialized assays that are not always accessible. So then next we show a context in here, that is non-small cell lung cancer, which includes LUAD, LUSC, that represents the majority of cases treated with immunotherapy. These subtypes each have distinct histologic and immune features, making them ideal candidates for AI-driven prediction. So here we show the biological mechanism behind the PD-L1 or PD-1 therapy. Tumor uses PD-L1 to suppress T-cell activity, and checkpoint inhibitors blocks this interaction to restore the anti-tumor immunity. So overall, this slide sets the stage for why AI applied to routine pathology images can complement or even surpass existing biomarkers by providing a scalable, unbiased way to capture tumor immune landscape and predict patient outcomes. So in the next slide, I'm going to show what we do if we are not going to benefit it from the immune checkpoint inhibitors. So first is there are novel biotech platforms like IMC Codex. There are different modalities and other multiplex technologies that generate rich spatial biology data, but they are expensive and they have scarce tissue. And the second, so there could be one direction, that is foundation modeling. So where we can use, where we can incorporate this spatial location of different patches using AI, using the features that we obtain from the foundation modeling, and we incorporate these features to get the spatial location, and we can develop our model for predict the patient outcome. The second direction is generative AI, so which can learn biological structure directly from H&E morphology. So this is one paper published in Nature Communications. So it is an in silico training model that can predict multiplex immunofluorescence patterns from routine histopathology, offering a scalable alternative to costly assays. So then the third is the predictive modeling, where AI learns patient-level signatures to predict patient treatment outcomes. The Kaplan-Meier curve on the right shows how model-derived biomarkers can stratify survival and potentially guide therapy decisions. So in the next slide, I'm going to show what kind of data that we have in MD Anderson, and so this is like an overall this dataset distribution for a small amount of patient, and so we have all of these different clinical factors available for the immunotherapy data. So then there are these different tasks that we are currently performing for the immunotherapy data in MD Anderson. So first is the histology, that is LUAD versus LUD, LUAD versus LUSC classification, then PD-L1 prediction, and then patient outcome prediction in terms of OS and PFS. So now I'm going to go over with some of the existing approaches that are specifically focused on this LUAD, LUSC or the lung immunotherapy area. So this is one paper which has been published in JAMA Oncology, where the study trained a deep learning model on routine H&E slides to learn morphological patterns associated with immunotherapy response in advanced non-small cell lung cancer. So the patient level scores were generated from patch level features and used to stratify outcomes, which were then compared against established biomarkers such as PD-L1, TIL, that is tumor infiltrating lymphocyte density, and tumor mutational burden. Performance was validated across an internal test cohort and a large external multi-institutional cohort. So on the left, you can see that patients with a high deep learning score had significantly longer progression-free survival and overall survival compared to those with low scores. This shows that morphology alone carries meaningful signals about immunotherapy benefit. The scatter plot demonstrates clear separation between responders and non-responders, reinforcing that the model captures biological relevant features linked to treatment response. On the top right, the response rate comparison shows that deep learning score outperforms PD-L1 expression in predictive objective response. Finally, the performance table summarizes how the deep learning biomarker compared to established biomarkers such as PD-L1, TIL, density, and TMB. The model consistently shows higher sensitivity and competitive specificity both in test cohort and in external validation. So in the next slide, this is one paper published in Nature Communication. In this case, the model was trained directly on whole slide images without requiring manual region level annotations. It learned to distinguish adenocarcinoma from squamous cell carcinoma using only slide level labels, making the approach scalable and pathology efficient. The ROC curves on the right show strong performance across multiple datasets, including external cohorts, confirming the model's generalizability. At the bottom, the heat maps illustrate how the model localizes diagnostically relevant regions despite never being given pixel-level supervision. These attention maps highlight tumor-rich areas and subtype-specific histologic patterns, reflecting the model's learned interpretability. Overall, this work established that weakly supervised deep learning can match traditional pathology performance while dramatically reducing labeling burden. So in the next slide, so this is a paper in Nature Communications again. So it's about automated cell annotation and classification, classification and histopathology for spatial biomarker discovery. This workflow uses self-supervised and domain-adapted models to classify individual cells on histopathology slides, generate spatial cell maps, and then extract spatial interaction features that are linked to immunotherapy outcome. On the right, the ROC curve shows that the spatial biomarker outperforms PD-L1 CPS in multiple cohorts, including Stanford and SMU, demonstrating stronger sensitivity at high specificity levels. The Kaplan-Meier curves show consistent stratification of patients into high and low risk groups across treatment settings, PD-L1 subgroups, and therapy types. Overall, this study shows how automated cellular phenotyping and spatial modeling on routine histopathology can reveal powerful biomarkers that outperform traditional ones like PD-L1. So this is in this paper, it highlights that introducing a model called BPH, a foundation model designed for generalizable cancer diagnosis and survival prediction from histopathology. The framework uses a two-stage strategy. First, large-scale self-supervised pre-training on millions of image patches to learn universal morphological features, and second, supervised fine-tuning for downstream tasks such as patch-level classification, whole slide diagnosis, and survival prediction. On the right, the box plot shows BPH outperforming or matching multiple state-of-the-art methods across several cancer types. The survival curves further show that the model can stratify patient risk more effectively than traditional multiple instance learning models like CLAM, highlighting its potential for prognostic applications. Overall, this work demonstrates how foundation models trained on diverse histology data can deliver robust, scalable performance across tasks and cancer types. So till now, I have discussed several models that are being designed for lung immunotherapy or lung publicly available lung data or in pan-cancer study. But in this slide, I'm going to present one of our works, which is under review, and how we planned to extend the existing multiple instance learning. So this is actually an end-to-end trainable multiple instance learning model that integrates multi-scale absolute spatial encoding and a top K neighborhood-aware loss and background suppression loss to jointly model global tissue structure and local microenvironment context from whole slide images. So this is the performance. We have validated our model on multiple cancer types and for survival and classification. So this is the performance on different data sets. So the next is like the more results on like different compared to the like which founder. We have used Uni 2 in our proposed method, but here is the comparison like how other existing foundation models perform compared to Uni 2. And this is like the heat map. This is the heat map for the model that we have proposed, and our proposed model is EagleNet, and we see that in the heat maps, the EagleNet, it has a smoother transition and it provides more attention to the required region compared to other attention mechanism like or MIL mechanism like gated attention, clam attention, and etc. So future direction is one is multimodal integration, like where we are planning to integrate different modalities like CT mode CT, then pathology, histopathology, then molecular level, and then we can combining all these modalities, we can perform, we can answer these clinical questions like diagnosis, treatment selection, response prediction, recurrence or progression, and death. So this is one direction. Another is spatial transcriptomics. So here in the spatial transcriptomics, this is integrating pathology with multiomics, enables precision oncology and deeper understanding of tumor integration, tumor immune interactions. Modern spatial profiling technologies now allows us to map tumor and immune cell interactions with high resolution, enabling discovery of powerful biomarkers that complement what we see on routine H&E. So this is my overall talk. Thank you for your attention and time.
Hello everyone. My name is Sai Preeti Nakina, and I'm presenting today on behalf of our team, the Patho Learners, as part of the SLC-PFM competition workshop. Over the next few minutes, I'll walk you through our project, which focuses on developing lean and efficient approaches for building cancer pathology foundation models. Our aim is to investigate whether lean, lightweight approaches can still offer strong performance. Ultimately, we hope to gain insights into how these approaches might play a role in future developments in pathology foundation models. Foundation models are large neural networks trained on massive data sets using self-supervised learning, where the model discovers patterns directly from raw data. This approach has transformed natural language processing because these models can learn from trillions of words collected from books, articles, and online text, all available in clean and standardized formats. With so much data, language models can grow extremely large and generalize across many tasks. General computer vision models also scale well because of millions of images that are publicly available. However, histopathology is very different. Data is limited, protected for privacy, and highly variable across hospitals and laboratories. Whole slide images contain billions of pixels, annotations require expert pathologists, and differences in staining and scanning create strong shifts in appearance. Because of these challenges, foundation models in pathology are typically smaller and harder to train, even though the potential clinical impact is very high. Pathologists face rising workloads and increasingly complex cases. Foundation models offer real potential because they can learn rich patterns from large collections of whole slide images, and we've already seen encouraging results in areas like metastasis detection, prostate cancer grading, and predicting gene expression from tissue images. But important limitations remain. Data is scarce and difficult to share. Variation across scanners and labs reduces generalization, and clinical deployment requires interpretability and strict validation. For now, these models should be viewed as powerful assistive tools, not standalone diagnostic systems. Pathology foundation models face major challenges. Recent progress has come from massive scaling. Models like Virtua 2 were trained on more than 3 million whole slide images, requiring enormous compute and making them inaccessible for most labs. But scale isn't the only answer. The Midnight 12K model showed that with the right algorithmic approach, far smaller datasets can match or even outperform these huge systems. Pathology also introduces unique hurdles: staining variation, scanner differences, artifacts, and the need to reason across many spatial scales. Generative methods that reconstruct pixels often miss the biology that matters. Our goal is to move beyond brute force scaling and reconstruction and instead build an efficient, practical model that real users can actually run. We start by leveraging the massive data set from the SLC-PFM challenge, which provides the scale we need during training. Our goal remains very focused: creating a lean model that downstream users can deploy quickly, even with limited data. A key part of making this possible is our pre-processing pipeline, which tackles the severe domain shifts seen across institutions. Differences in scanners, staining protocols, and slide preparation can greatly reduce model generalization. To mitigate this, we apply robust stain normalization strategies to align color profiles across samples. We then add an additional layer of color correction through HSV filtering to stabilize texture and color variations. This combination allows us to train at massive scale but deliver a compact, consistent, and highly deployable model. In pixel-level reconstruction, the model predicts masked pixels directly. This allows it to capture fine-grained textures and low-level details, and the training objective is simple and stable. However, it comes with major downsides. It's computationally expensive, especially for gigapixel whole slide images, and it overemphasizes irrelevant variations like stain intensity, lighting, or scanner differences. As a result, it struggles to capture high-level semantic features that are critical for pathology tasks. On the other hand, latent semantic representation methods like IJAPA focus on predicting abstract embeddings of masked regions. This approach efficiently captures meaningful tissue morphology and structure, is more robust to domain shifts and artifacts, and scales well without requiring multiple augmented views. The trade-off is that these models capture less pixel-level detail and require more sophisticated architectural design. Additionally, this is a relatively newer approach, so tooling and benchmarks are less mature. The SLC-PFM competition gives us a unique and powerful setting. It provides the largest pathology dataset ever released for benchmarking, with over 300 million images across 39 cancer types. This allows us to focus entirely on developing novel architectures rather than spending time on data curation. Our approach centers on IJAPA, an image-based joint embedding predictive architecture that is particularly well suited for pathology. Unlike pixel reconstruction methods that waste computation on unpredictable, noisy cellular details, IJAPA predicts the latent semantic features of masked regions using meaningful contextual information. This helps the model capture biologically relevant morphology while scaling efficiently. We will also test architectural variants. DMT-JAPA constructs more discriminative targets from semantically similar neighboring patches, pushing the model to learn finer local distinctions. We will further explore across-scale JAPA, encouraging consistent representations across 10x and 20x magnifications to mirror how pathologists reason across scales. To enhance robustness, we incorporate the Barlow twin loss to decorrelate feature dimensions and produce non-redundant embeddings. Finally, our compact model will be evaluated on cancer classification and segmentation tasks using standardized competition datasets coupled with detailed ablation studies to quantify the contribution of each architectural component and guide further development. Thank you for your attention. Feel free to reach out to us if you have any questions.
Welcome to the University of Kentucky's Center for Applied Artificial Intelligence. Visit us online at caai.ai.uky.edu to learn more.
On behalf of the Appalachian Trail team, I wanted to thank the organizers for the opportunity to share our thoughts and work. From Southern Appalachia in Georgia to Northern Appalachia in West Virginia, our collaboration has grown through visiting scholars from Karabük University in Turkey to institutional collaborations with the University of Louisville and the establishment of the Kentucky Pathology Data Trust. As with many of you, we believe the development of foundational models that can self-supervise through domain-specific methods are the next evolution of model development. It's also important that we work together, not just to develop techniques, but to establish diverse data representations from across the globe. As foundational models are able to understand complex domain patterns, generative AI can replay these understandings to advance scientific discovery and clinical care. In addition to model development, our work focuses on leveraging parameter-efficient fine-tuning and model layer replacement at time of execution, allowing for strong generalized foundational models to be adapted to many downstream tasks efficiently and for operational purposes within a common ecosystem. We thank you once again for the opportunity to share our work and look forward to future collaborations.
Our team's first priority was to understand and structure the large unlabeled competition data set by using existing pathology foundational models. To ensure we are feeding our model with high-quality data as we scale, we are moving away from simple k-means to a consensus clustering approach. We hypothesized that if an image falls into the same cluster across Unitu, Conch, and Phycon, it's more likely to represent a pathological concept rather than noise. We will use statistical methods and inspection from our team's pathologist, Dr. Gondim, to verify this. Then we can construct a seed data set from the pseudo-labels constructed by our approach to begin the training of our model. This seed data set serves two purposes. It can serve as a test data set to evaluate our model via linear probe, and it can directly be used to train our model via contrastive loss, where the model will learn to push images in the same class towards each other in the embedding space and to push dissimilar images apart. We plan to use this learning objective as an initial warm-up phase, giving the model a baseline understanding of the data before introducing other self-supervised learning objectives. This image shows the UMAP visualization of the clusters we generated in our preliminary experiments with Unitu embeddings. After creating our baseline model, we will utilize a DynoV2 style self-supervised learning architecture. This relies on a multi-view student-teacher framework where both networks are vision transformers. We leverage this design to enforce multi-scale learning, generating hierarchical representations across 20 times and 40 times magnifications. The student model is fed local crops representing the higher magnification details constructed using standard pathology-specific augmentations. The teacher, conversely, sees global crops, which are high-level, less augmented versions of the original image. The student is trained to predict the same embedding representation as the teacher, while the teacher is updated as an exponential moving average of the student's weights. To optimize training stability, we have integrated Optuna with Weight Watcher. Optuna acts as our automated hyperparameter optimization framework, searching for ideal configurations for parameters like global learning rates. Complementing this, Weight Watcher provides a principled method for health monitoring. By analyzing the spectral density of the weight matrices, it enables an adaptive learning rate policy that adjusts the learning rate for each specific layer based on its training state. This prevents overtraining within specific layers, and it accelerates the model's overall convergence. Foundational models are best trained on diverse, balanced datasets. Typically, balancing involves trimming the dataset to remove overrepresented labels. However, we aim to utilize the full dataset by implementing a novel balancing approach. We employ a multi-expert distillation training strategy to handle any imbalances we discover. In this strategy, the model parameters are distributed across GPUs using FSDP, or fully sharded data parallel. Each cluster in the dataset is then assigned to a separate GPU, allowing an expert model to be trained specifically for that cluster. Finally, these expert models are distilled into a single unified model representing the ensemble averaged knowledge of all the experts. This approach mitigates bias towards overrepresented clusters and ensures that each expert model is trained for an equal number of steps on its assigned data, promoting balanced generalization.
A powerful advantage of training a foundational image model is that it becomes a shared backbone for a wide range of downstream tasks.
Using modern parameter-efficient fine-tuning frameworks, such as PEFD and LoRa, which stands for low-rank adaptation, we can attach lightweight adapters to the foundational model without retraining or modifying its core weights. These LoRa adapters can be swapped in dynamically to specialize the foundational model for tasks like tumor classification, cell type detection, or even pixel-level segmentation, all while keeping the same base model frozen. This design makes the pipeline both scalable and efficient. Because the only unique components for each task are small adapter layers or lightweight heads, GPU memory requirements remain low. You avoid the overhead of hosting multiple large models and instead maintain a single foundational checkpoint, adding adapters only when needed. In clinical environments, where hardware may be limited but the diversity of tasks is high, this approach offers a practical path to deploying AI systems that remain versatile, updatable, and resource efficient. With our data curation and training strategy in place, our immediate next step is applying this full pipeline to the complete competition dataset. We are confident this approach will yield a robust, clinically useful foundational model. Thank you.
Good afternoon, everyone. I am Mamunur Rahman from the University of New South Wales, Sydney, Australia. Today, I'll present PathDFM, a foundation model designed specifically to address the multi-scale and non-independent nature of computational pathology. This is a collaboration between UNSW, Emory University, and the NSW Health Pathology for the NeurIPS SLC-PFM competition. So the current foundation models treat whole slide images as a bag of patches. As you can see on the left, standard SSL treats every tile as independent, but biology doesn't work that way. A patch meaning depends entirely on its context, like whether a lymphocyte is inside a tumor or out in the stroma. Current models fail to capture this spatial context, and they struggle to link the cellular details at 40x with a broader tissue architecture at 5x. We built PathDFM to solve this. Here is our solution. PathDFM unifies three components: hierarchical backbone. We fuse multi-magnification views simultaneously. Stage 1, dual objective. We don't just use distillation, we combine it with masked image modeling. This ensures we capture both high-level semantics and fine-grained reconstruction. Stage 2, context. We explicitly model the relationship between the neighboring tiles. In stage 1, we tackle the scale problem. We use a teacher-student setup. The teacher sees the global view, tissue architecture, while the student sees the local view, cellular morphology. By forcing the student to match the teacher, the model learns that these specific cells belong to this specific tissue type, creating a scale invariant representations. In stage 2, we tackle the context problem. We stop looking at isolated patches. We freeze the backbone and treat the entire image as a sequence. We mask the center tile and force the model to predict it using only its neighbors. This forces the model to learn the syntax of the tissue, understanding critical spatial features like tumor margins. Pathology models overfit to scanner-specific stain profiles. To overcome this issue, we use aggressive normalization and color jittering to strip away these non-biological cues, forcing the model to focus purely on structure. For the competition, we are currently in phase 1. We have completed training the architecture on the initial 45 million image subset using the UNSW Katana HPC. Since the official validation set is not yet released, we analyze the structure of our embedding space using 10,000 held-out images. You can see the UMAP visualization on the left. On the bottom, Dino version 2 features are entangled. The bar chart on the right shows feature collapse where cluster 2 is nearly empty while cluster 3 dominates. On the top, path DFM clearly separates semantic concepts into distinct clusters. Quantitatively, we achieve a 135% improvement in silhouette score compared to Dino version 2. This proves that our context training is actively disentangling complex tissue structures. Moving forward, we are standing by for the release of the full 300 million image dataset. Once the official guidelines are released, we will fine-tune it on the downstream task. In summary, Path DFM shifts the paradigm from patch-based to context-aware pathology. By unifying multi-scale vision with explicit spatial modeling, we generate features that are structurally superior and clinically meaningful. Thank you very much for your attention. We believe Path DFM is a step toward making foundation models truly understand the language of pathology. I am now happy to take any questions.
Hi everyone, we are Team EMET from South Korea, and it's a great pleasure to be part of this competition. Firstly, we thank the organizers for letting us to present at this workshop. We feel sorry that we couldn't make it in person, but we hope our insights could reach you all. This competition aims to build a generalizable pathology foundation model based on self-supervised learning. The data set consists of 39 cancer types from 3 origins and 5 different scanners. While previous studies in PFMs ongoing, there are still limitations in their ability, given that each model is trained on different data distributions and different optimization strategies. As a result, they capture slightly different feature domains, which leads to poor robustness and generalizability. To address this issue, we propose a fusion-based approach that integrates embeddings from multiple models into a unified representation. By efficiently reusing pre-trained knowledge from diverse models and consolidating their unique feature domains, our method aims to improve its generalization among various data. We would like to start off with introducing our architecture. Our architecture consists of 3 main parts: data preprocessing and 2 training phases, including fusion network and model distillation. Each part will be discussed further in detail. The data preprocessing stage includes patch selection and patch augmentation. We selected patches with over 70% of tissue content and a Laplacian variance above 50 to remove blurry and background dominant patches. The thresholds were determined empirically. We are experimenting with various augmentation methods to decide the best method that fits with our model. First, our goal is to normalize the color variance over patches from different vendors. To mitigate this issue, we utilized RenStain-NA framework to efficiently apply stain normalization and stain augmentation. We are also experimenting with augmentation methods that are widely used in natural image datasets, such as flip and rotation. With further experiments with more normalization and augmentation methods, we will decide the finalized method and the percentage of the data to apply it to. We explored a multi-teacher model fusion approach based on the idea that different pre-trained models capture different aspects of the input data. To make fuller use of the pre-trained models, we first LoRa-based fine-tuned them on the data set and then fused the representations to obtain a richer and more complementary representations. Teacher model selection was guided by both prior research as well as our internal evaluation results, leading to Workout 2, Uni 2, and Conch as a final step. The fusion module was implemented as a lightweight transformer encoder and trained using an InfoNCE contrastive loss. To ensure that the student does not simply replicate the fused teacher features, but instead develops a more independent representation, we added a distillation stage. Insights from prior work demonstrated that combining diverse self-supervised learning objectives can lead to complementary representations. Inspired by this, as the teacher models were trained on Dino and iBot, we used cosine similarity and Huber laws for the distillation objective and employed a MoCo V3 style contrastive loss for the students' learning. The overall design was also kept so that the final model satisfies the single GPU inference requirement. We have constructed an internal evaluation framework to evaluate the performance of our model. This framework includes various downstream tasks, including classification, image retrieval, and survival prediction. The test set consists of 1,074 WSI slides from the TCGA, BRCA, and LUAD cohort, but we are planning to expand this test set with more tasks available. So far, we have evaluated our performance on the fusion representations, which shows improved performance on several downstream tasks. While retrieval and survival prediction have not yet surpassed the pre-trained baselines, we plan to continue refining our approach to strengthen performance in these areas. We hope our work contributes to building a more generalizable pathology foundation model, and we look forward to the discussions and insights shared throughout this workshop. Thank you.